My birth story of hope is when I first started off with doing my pregnancy journey, I really wanted an all-natural birth, no epidural. I was doing all the deep breathing and doing all the different poses to have a natural, healthy birth. When it came to the actual delivery day, we ended up having to have a C-section because my baby was in distress. And at that time, we didn't understand what the distress was. And I had called my mother and my grandmother, and they came up to the hospital where I was. I was not ready for that. And I had processed this whole natural experience. We were rushed back into the operating room. Everyone was very lovely. They let me pick the songs that I wanted. I didn't know what I was gonna have, but if it was gonna be a girl, I wanted them to play Isn't She Lovely? And I think it was Signed, Sealed, Delivered if it was gonna be a boy. When the baby finally came out, Noelle, we found out that she had swallowed some meconium, so that's why she was in distress. And so because of that, she had to go into the NICU. And so I really didn't have the time to put her on my chest and to bond with her. I could see her off in the corner, and they weren't telling me what the gender is, and they weren't saying anything. It was kind of quiet. I could hear the baby crying, so that was positive for me. They played Isn't She Lovely, so I knew it was a girl, so I was super excited about that. And so finally, they let me roll down there, and it's like, you can't stay long. I was just really emotional. I'm so glad that I had my mother and my grandmother there. It made me really think about the experiences of people in my family with their childbirth experiences. My grandmother with her first child, she had a stillbirth. I'm glad that my partner was there throughout the whole journey of my pregnancy. Every doctor's appointment that we had, he was there, and so it was a team sport. The system is in place for you to have a healthy, happy birth. And I'm glad that I had a trusting relationship with my healthcare provider, so I really took her advice and trusted her despite my own fears and apprehension. My baby is safe and healthy, and I made a decision that was very wise to have the C-section for her to be here, to have a great life and a life on her own terms.
Okay. Okay, so happy Friday. That was me. Hello. Thank you. Hello, and welcome to the Johns Hopkins Bloomberg Center. My name is Dr. Lauren Parker. I am a mom, I am a granddaughter, I'm a daughter, I'm a sister, I'm an auntie, I'm a friend, and I'm an advocate for those birthing moms out there. And I'm also an associate scientist at the Johns Hopkins Bloomberg School of Public Health. It is my pleasure to serve as the mistress of ceremonies today. I plan to keep everything moving so that we are fast, but we're still here for a purpose. I want to welcome everyone who is here in the audience. Thank you for coming on a Friday right before Memorial Day weekend. We want to bring in the festivities with you all. And I also want to acknowledge and thank those who are online. I also want to remind everyone that lunch will be available following today's events. We will start this morning's event with a welcome from leaders from 2 of the 4 coordinating partners for today's events. First, we will hear from my good friend, Dr. Roland Thorpe, the Associate Vice Provost for Faculty Diversity at Johns Hopkins University and a professor at the Hopkins Bloomberg School of Public Health. Dr. Thorpe is a gerontologist and a social epidemiologist with national recognition and expertise in minority aging, men's health, and place-based disparities. Immediately following Dr. Thorpe, we will hear from Ms. Nicole Austin-Hillary, the president and CEO of the Congressional Black Caucus Foundation. A civil rights lawyer by training, Ms. Austin-Hillary has served in high-profile roles at Human Rights Watch, the Brennan Center, the Washington Bar Association, and the Lawyers Committee for Civil Rights Under the Law. Please give a warm round of applause for Dr. Thorpe and also Ms. Nicole Hillary, Austin-Hillary, excuse me.
Thank you so much. Good morning, everyone. That's great. That's great on a holiday weekend. I'm very excited to be here today. It's my great pleasure to welcome you to the 3rd Health Opportunities for Policy Equity, affectionately known as HOPE Challenge Policy Forum, hosted by the Johns Hopkins Center for Health Disparities Solutions. Today we gather with a shared purpose and a collective commitment to addressing one of the most pressing issues of our time, closing disparities in Black maternal and infant health. I'm gonna say that one more time. Closing disparities in Black maternal and infant health. Thank you for joining us in this vital discussion. Your presence here today signifies a profound dedication to improving health outcomes, ensuring equitable care for all mothers and infants, regardless of their racial or socioeconomic background. Now, the issue of maternal and infant health disparities is not just a statistical or a policy challenge. It is a deeply personal and urgent human rights issue. For far too long, Black mothers and their babies have faced disproportionately higher rates of adverse outcomes driven by systemic inequities, structural racism, and social determinants of health that disadvantage Black communities. Today, we come together to not only acknowledge these disparities, but to chart a path forward toward meaningful and sustainable change. At the Johns Hopkins Center for Health Disparities Solution, our mission has always been to illuminate the root causes of health inequities and develop evidence-based strategies to eliminate them. This forum is a testament to that mission, bringing together a diverse array of voices and perspectives to engage in robust dialogue, share innovative solutions, and foster collaborations that would drive policy and practice toward greater equity. Our discussions today will be enriched by the insights and expertise of our distinguished speakers and panelists, who will provide a comprehensive understanding of the multifaceted challenges and opportunities in Black maternal and infant health. We will explore critical roles of policy, community engagement, healthcare practices, and advocacy in creating environments where every mother and child can thrive. Together, let us harness the collective power of our knowledge, experiences, and passion to advance solutions that will close the gaps in maternal and infant health outcomes. Let us commit to sustained efforts informed by data and driven by compassion to ensure that every mother and baby receives the care and support they deserve. Thank you once again for being here today. I look forward to the meaningful conversations and actionable insights that will emerge from this forum. Let us together create a future where health equity is just not an aspiration, it's a reality. Welcome.
Good morning. I am so privileged and pleased to be here with you all this morning. I am Nicole Austin Hillary. I have the privilege of serving as the president and CEO of the Congressional Black Caucus Foundation. I want to give a special thank you to Dr. Maya Rockeymoore Cummings for her vision and for bringing us all together under the auspices of the Hope Challenge. We have work to do. We have work to do. And this issue of Black maternal health and equity, it is not just a nice subject line among subject lines. It is the core of what we mean when we talk about race, democracy, and equal justice. When we talk about these issues, everyone needs to understand that the health and safety of Black mothers, their children, their families, that is at the core of what we have to focus on in this country to keep us moving forward. These women, these mothers, these warriors are the backbone of so much advancement in this country. And if we are not taking care of them, we are not taking care of our democracy. So I want to make sure that we position this issue where and how it should be positioned. We didn't come here today to just talk to one another and have interesting conversation. We came here today to be part of a movement, to be change makers. I was sharing with some of the other speakers when we arrived today that it is lovely that we get together and everybody looks nice, and I'm sure you all are super intelligent and smart, but we came here to walk out with a purpose and with action items in place. I tell people I no longer want to be engaged, and the foundation no longer wants to be engaged in conversations where we have, at the end of the day, a nice binder of notes that you can take back to your office and you can put on a shelf, and that will collect dust. we are in a moment where we have to stand up and stand out and speak up and speak out about these issues. And that's what we are here for today. And that is really the underpinnings of the Hope Challenge, to empower everyone with the tools needed to go out and be change makers. And I challenge you not just to keep it to yourself. It is not just for you. It is for you to take to the communities in which you live, to take to the organizations with which you are engaged. It is for you to take to the person next to you sitting on Metro. It is for you to take to your community organizations. That is how we create change. That is how we empower one another. Because it really is a collective action that has to take place. It is really about collaboration. That's how we will make certain that these issues that you just heard the doctor speak of, that data, those numbers, that is how we bring them to life. And I implore all of you to be forward and brave in taking that charge forward. You know, at the Congressional Black Caucus Foundation, when Dr. Rocky Moore Cummings called and said, we want you all to be partners in this Hope Challenge, we immediately said yes. Our mission is to empower the global Black community. And we know that we do that through information, through education, through research, through data, through policy forums like these, and by working and standing arm in arm with other foot soldiers, which is what you all, which is what Johns Hopkins is. That's why we collaborate and do this work. You know, I had the pleasure, one of the speakers you're going to hear from today, Dr. Creer Perry, was just with us at the Congressional Black Caucus Foundation earlier this week. We had our Policy for the People Health Summit. So it is fitting that I'm coming here today just on the heels of that event, where we too charged and employed another set of foot soldiers to take this work, take this information, and be change makers. That is what I am excited about today. And I'm also excited about the truth telling that will go on in this room. These are hard issues. These are difficult issues. But it is up to all of us, the experts that you will hear from today. It is up to all of us to make certain that we are telling the stories, like the stories you heard at the beginning. It is important that we give space to the voices that often go unheard, the mothers who are in rural communities who may be forgotten, the mothers who are in places who think that they are well situated and are going to get the best care, but find out that because of race, class, economics, that they are not being treated as they should be, and their calls for help are going ignored. That's what we are all here for today. So I thank you for being here. I thank you for this opportunity and for including the Congressional Black Caucus Foundation in this work. It truly takes a village, and I am excited about what I know you all will do. As I said at the beginning, we have work to do. But I am not dismayed by these numbers and by the data. I am buoyed. I am feeling empowered because the fact that we are all together and recognize the power that we have in collective action, I know that has created a foundation for success in the future, for opening opportunities, for giving voice and power to the many mothers and families that have to tell their stories. And I know that collectively and collaboratively, we will make a difference, and we will ensure that this country is true to its principles, which is equity for all, because that is what is at the core of this issue, creating equity and opportunity. So please go forward, be brave, be truth tellers, and make a difference. And thank you for allowing the Congressional Black Caucus Foundation to be your partners in this work. Thank you, and have an empowering morning.
Wow. Let's give another warm round of applause for Dr. Thorpe and also for Ms. Austin Hillary. It is now time for our first panel. Can the panelists please come up to the stage? While they're doing so, it is my pleasure to introduce you all to the panel's moderator, Ms. Suzanne Malveaux, an award-winning journalist, the president and CEO of Malveaux Global Media, with more than 30 years of reporting, producing, and storytelling experience. Malveaux recently left CNN after 2 decades of bringing groundbreaking journalism to the network. There she covered the White House for 10 years, interviewed 5 US presidents, embedded the US troops in Afghanistan while breaking news of a terrorist attack, and most recently traveled to Ukraine to report on the war. Malveaux has won numerous awards for her anchoring and series on ALS. She's produced a 90-minute documentary on former President Barack Obama. Suzanne, take it away, and thank you so much for joining us today.
I believe we're going to first see a quick clip here from the documentary, Listen to Me.
I think the Black maternal health movement is very, very old. And it began on the journey here when Black women made the decisions to throw their babies overboard rather than have them being born to wherever they didn't know they were going or what was going to happen to them. But they intuitively knew that it was not a good thing.
If you ask me from a non-scientific medical place, I completely blame my infertility on years of night call, years of chronic stress, and predominantly white institutions.
I'd never been pregnant before, so being pregnant with twins was tough.
Shalon had a huge village, and they all were so loving of Shalon.
I didn't know what pregnancy felt like. Blood pressure was fine, everything looked good. Went to sleep, but this head just would not go away.
She told them the symptoms, she expressed them very clearly. 3, 4, 5 visits, and nothing was done.
Where else do you go? Who else is out there? Your pain and to what you're dealing with.
Everything, puncture, Chinese medicine. Tired of the so tired of the appointments. I can't wait to let go of all of that.
Do everything right, you have the resources, you have the knowledge, but it still is not enough to save you. Then what's the answer?
Thank you very much. That is a documentary, an excerpt from Listen to Me, and one of the co-directors we actually have the honor to speak with in one of the panels this morning, so we're really looking forward to that. Our voices are so powerful, and storytelling is such a big part of really getting the message out. And when we tell our own stories, that is when we shape the narrative here. And so I just can't underscore really just the courage that it takes to turn the cameras on oneself and to share in one's intimate storytelling about the births. And I really do hope that all of you get a chance to see this incredible documentary. Good morning, thank you very much for having me. I know that this is such a critical issue during this time, and we all have, in some ways, personal stories to tell. I know in my own family, I have relatives who went through emergency C-sections and life-threatening situations during childbirth. So this is not really new to us. My father, Dr. Floyd Malveaux, as Dean of Howard's Medical School, dedicated his career to focusing on health disparities in the Black community and the underserved. So we are no stranger, really. These are kitchen table conversations to this topic, but much of the nation is really unaware of what is happening, and it is a maternal health crisis. Despite the advances in medical science and in technology, the statistics are quite alarming, and we will, in this first panel, go through the policies and some of those numbers and translate that into what that really means for all of us as families. But I just want to put this out first, that Black women in the United States are 3 to 4 times more likely to die from pregnancy-related causes than white women. And that is important it's worth repeating, that Black women in the United States today are 3 to 4 times more likely to die from pregnancy-related causes than white women, and this is regardless of income. According to Yale University, 84% pregnancy-related deaths are preventable. Additionally, the infant mortality rate for Black babies is more than twice that of white babies. Now, as was mentioned before, these disparities, these numbers, it is not just statistics. It affects all of our families. It affects our community, as we saw in that video previously. And so today, it is really an honor and a pleasure that we are with such a distinguished group of panelists and experts on this subject. I've had a chance to talk with some of them for a little bit, and we have an all-female panel, by the way. I'm sure that has not gone unnoticed, but power to all of us, to all of our sisters. But they are dedicated to understanding and addressing the systemic factors that contribute to these inequities. So I'd like to start off by introducing our panelists, and then I'll give a little brief overview of some of the things we hope to talk about. We have just an hour, and Maya, you're going to keep me honest about the time. And thank you so much, Maya, for the invitation as well as Johns Hopkins. We hope to also perhaps get some time at the end for some Q&A from the audience. If you have some burning questions, we have a microphone, and we'll try to get to that. Our panelists, Dr. Yolanda Lawson, a leading obstetrician gynecologist, Black maternal and child health expert, and current president of the National Medical Association. Would you please stand? Thank you. Dr. Kanika Harris, a researcher and advocate who has, as the director of Black maternal and child health at the Black Women's Health Imperative, worked tirelessly to influence policies aimed at reducing Black maternal and infant health care disparities. She is also a doula as well, and she is one of the co-directors that you just saw of the documentary, Listen to Me. Please stand. Congratulations. Dr. Jamila Parrott is an OBGYN with extensive experience in family planning and reproductive health. She serves on the Maternal Mortality Review Committee for the District of Columbia and is the president and CEO for Physicians for Reproductive Health. Please. And finally, Dr. Dora Hughes, a longtime health policy and health equity expert who currently serves as the acting chief medical officer and the acting director of the Center for Clinical Standards and Quality for the Centers for Medicare and Medicaid Services. So together this morning, we are going to explore the reasons behind this maternal health crisis, including the socioeconomic factors, the implicit bias in healthcare, the access to quality care, and the impact of chronic stress and discrimination on health. Our goal really is not just to shed light on these issues, but also to discuss what are some of the actionable policy solutions that can lead to better health outcomes for Black women as well as infants. We're going to begin this important conversation urging everyone to keep an open mind in their commitment to change. And we know that the disparities that we are addressing today are really deeply rooted and they are complex. But with collaboration, with all of us together in these kinds of conversations, with empathy and determination, we can make progress towards equitable healthcare system. So thank you again for joining us, and we will start by having each one of our panelists give about 5 minutes. We're going to try to keep it brief so we can get each one of you 5-minute round, and then we'll start our discussion. Thank you. Dr. Lawson.
This is supposed to be simple, and I have a degree.
Is
it
working?
on?
Yes,
There we
it
go.
is. There you go.
I'm looking for the on and off button. Good morning, everyone, and thank you for having me today. Really happy and excited to be here. Happy to talk about this topic. As she stated, I'm the president of the National Medical Association. That's the largest organization of Black physicians in this country. I'm also an OBGYN by specialty, and I'm in the state of Texas, so yes.
Special challenge.
Yes, special challenges for me. And so really happy about this discussion. We know that we just got the numbers from the CDC about 3 weeks ago, the 2022 numbers. And while we saw there was a decreased rate overall in maternal mortality in this country, there's still that disparity for Black women. And so if we're going, for me, this is not just a health equity issue, right? If we really are committed to safe birthing processes, positive health outcomes for everyone, this affects everyone. So I think one of the things we've got to start talking about more is what's the return on an investment for the country. There's an economic factor here. We know we've got to address the non-clinical factors around this. I'm hoping we can explore some of this, technology, the workforce. I'm doing a lot of work on that space. We know we need to expand the maternal health care workforce. So really looking forward to the discussion today, because this is a disturbing thing that this is persistent. The other day, I don't get to see the news much, but I saw that some folks just went into space. Some folks just went into space for leisure, right? We're going into space for leisure. Think about what that means to the communities. When I go to communities of color, they are going into space, and we can't solve this problem. That's a problem, Houston. Thank you.
Thank you. Dr. Harris.
Good morning. I didn't know who I was sitting next to. Wow. That's amazing.
I told you.
Good morning, everyone. So I'm very honored to be here. I'm Kanika Harris. I am the Senior Director of Maternal and Child Health right now at the Black Women's Health Imperative. We are most known right now in the maternal health space for our program Nourish, which stands for New Opportunity to Uncover Our Resources, Intuition, Spirit, and Healing. And what that was about, when I thought about creating that, I was thinking about how do we comprehensively, holistically address what's happening to us in a way where we can take back our power. When I looked at the HBCU landscape, though that's the institutions where we're gonna have the leaders in STEM and research and technology help us to solve these issues, yet we're divesting in those institutions, right? We don't even have the reproductive knowledge. We don't have schools of public health. We don't have midwifery schools. We don't have maternal health programs. So what can I do to infuse this knowledge into our communities that would naturally and normally be infused had we not just really obliterated and destroyed midwifery in this country? So how do we do that? So my idea was to train college students to become doulas. And by doing that, they had to do full spectrum doula, from learning about themselves, doing group health counseling, individual counseling, learning about themselves first, before they could support and help their communities. So we trained 42 students. They were grad students, midwifery students, college students to become doulas. And so what that program has done is increased the perinatal workforce. Women on college campuses, I just found out a statistic that 58% of Black women over the age of 20 have hypertension or are pre-hypertensive, right? So we wanted to get those numbers early. We wanted to prepare them for birth, whether they decided to give birth or not, but just infuse this information into the community. And by doing that, we recreated community, we recreated village, and we are infusing this knowledge so it's not something you only have to find out through your provider or through your medical system. So I'm really proud of that program, and we look to expand and continue that. Thank you.
Thank you.
Same thing, all the degrees, and still owe money, and can't figure out how to work the mic. Good morning, Dr. Jamila Parrott. I use she, her pronouns. You heard in the introduction. I'm the president and CEO of Physicians for Reproductive Health. We're a national organization, a network of doctors around the country really organizing and mobilizing healthcare providers to advance access to reproductive health for the communities that we care for and claim to care about. I'm a practicing OBGYN here in the city that I grew up in, the city that made me, Washington, D.C., and provide abortion care for my community here as well. You know, never been parsimonious with my words, but I'm gonna try to stick with 5 minutes. You know, you heard the numbers, we know the numbers, and so rehashing them over and over again I don't think is what we're here to do. There are a couple of things, though, I think worth pointing out, right? One, we heard a little bit about the majority of deaths, anywhere estimated between 60 to 70% of deaths are preventable. So I really don't tend to talk about maternal mortality or morbidity from a point of disparity, but instead of inequity because of the preventability factor, right? Disparities are simply differences, right? I had chicken for dinner, you had fish for dinner. These are things that we can prevent, and we have consciously chosen not to do so. The other thing that I think is important to understand is that these inequities are disparate and they are uneven. So they impact some communities more than others. And so we're talking today about Black women and birthing people, Indigenous women and birthing people as well are experiencing similar inequities. We see these inequities and outcomes as well for young people, LGBTQ folks, those living in rural environments. So when we're talking about the causes, we really have to think about the complicated lives that our communities live. And those solutions have to be grounded in that context. They have to be grounded in those complications as well. I mentioned that I grew up here in D.C., and D.C. is really a tale of two cities. It's a place where that has some of the greatest income inequities of any city in this country. The top 10% of earners make 6 times more than the bottom 10%. And we're experiencing, like many other cities, the impact of racial dislocation as a result of gentrification and cultural elimination for so many in our communities, and that contributes to our health outcomes. When folks show up into our offices, they are not showing up as an individual living in a vacuum. They're showing up with all of the context that surrounds them, with their experiences, their lived experiences, their community experiences, both the oppressions, but also the successes, the resilience. And so it is our opportunity and our obligation to really think through those things when we're seeking solution. And I know we're gonna spend a bit of time talking about opportunities for solutions, and so I'll save my remarks for that piece, but I want to mention one thing that hasn't come up yet, and if you'll indulge me for just a couple of minutes. You know, I am a practicing OBGYN, as I mentioned, but it wasn't until I was well out of med school, out of residency, out of fellowship, out of graduate school, well into practice before I heard the term reproductive justice. And I think that that is something that is critical to bring into the room this morning, because that is the foundation for all of the work that I do, and it is the only way we gonna get free. And reproductive justice is a framework, a theory of praxis that was developed by 12 Black women in 1994 who were meeting at the pro-choice conference in Illinois, in Chicago. And they were talking about their lives as Black women living at these intersections and not wanting to use the language of choice that was popular at the time. Instead, they brought together human rights, social justice, and reproductive rights to coin a new term, reproductive justice. It rests on 4 pillars. Every person has a human right to determine if they have a child and the circumstances and conditions under which they give birth. Every person has a human right not to have a child and to have the information and resources necessary to end or prevent a pregnancy. Every person has a human right to parent the children we already have in communities that are safe and sustainable and free from violence from the individual and the government. Every person has the human right to bodily autonomy. I bring that up because I think it's important that even though we're talking about maternal health on its surface, reproductive justice is critical, because you cannot have birth justice if you do not have abortion justice. You cannot have abortion justice if you do not have the right to feed your children healthy food, to give them clean water to drink, to send them to safe schools, to allow them to walk down the street without the threat of violence. All of these things go hand in hand. So as we're moving through this discussion and we're talking about maternal health, I want to encourage us or invite us not to think about it as an isolated issue, but as all of the things that come together to form our health and well-being in the world. I look forward to the conversation. That was probably like 7 minutes.
We'll dock you. Dr. Hughes.
Thank you, and thank you for inviting CMS to join the panel today. I'd be happy to loan you a couple more minutes. This has been really helpful, and I'm very much looking forward to the discussion. For many of you, if not all of you, know that the Biden-Harris administration made maternal health a top priority, and they issued calls to action across all of the departments and agencies, particularly the Department of Health and Human Services, of which CMS is part of. And I'm proud to say CMS, our agency, certainly responded to this call. We have issued a 5-part maternal health action plan that you can find online. We've held a maternity health summit. Our administrator, Chiquita Brooks-LaSure, has really emphasized, too, as part of, even as CMS is moving forward, and we will continue to do so, that has also to be done in partnership. We cannot do it alone, and she has called on the private sector, the public sector, state and local partners to join us in this effort. As part of our priorities, I mentioned our action plan. We are really focused in 5 areas, 5-ish areas. I noticed that some of the areas continue to expand, but I would say 5 core areas. The first is, how are we focusing on access? How are we providing access to all of the care that women need, from pre to peri to postpartum? And as part of access, not just coverage, whether it's Medicaid, Medicare, Marketplace, coverage, but also, are you having access to the institutions, to the providers? How are we thinking about workforce? So it's meaningful coverage that we're providing. The second area is really focusing on quality of care. Are women, are they getting the evidence-based, the recommended care? And even as we're thinking about the quality of care in the traditional clinical sense, we're also increasingly focused on patient-reported outcome measures, patient-reported experience measures, PROMs, PREMs, as people describe it. And so that's increasingly looking for measures of, are you being listened to? How are you, what is your experience when you go into care? Not just, are you receiving the evidence-based care that you should be receiving through all stages of your pregnancy. The third area is really focusing on social services. We know that many women need assistance with housing or transportation, or is it food? Are we connecting with our social service partners so that women are getting the care that they need very holistically? That is a theme that you will increasingly see across CMS programs. The fourth area is data. Not always that exciting when we just say it like that, but it's really helpful for us to know, where do we need to target our efforts? How are we doing? How can we monitor our performance? How do we hold ourselves accountable? And some of the data we have at CMS, in other cases we're trying to be creative. Beg, steal, or borrow comes to mind as we approach our colleagues at CDC, for example, or HRSA. What data do you have that we can overlay with the data that we have to really help, again, to improve the care that we're able to provide? And the fifth area, in many ways, is the most exciting: innovation. We know in so many cases what works. And in many cases, we don't know exactly what works best. But even for those that we do know, we've demonstrated this over here. We've done a pilot test over here. We know that Medicaid is doing this and certain states are doing that. As part of our upcoming innovation model that we've announced, we're trying to think about, what can we learn if we package them together? What can we learn if we add a payment component? What can we learn if Medicaid is working together with the private sector, with state partners? How do we scale it up? We will be soliciting applications in the summer. We anticipate rolling out this model, or demonstration, if you will, early next year. And we are really excited to think about what we will learn by doing big things at scale with a national focus that will then be able to inform many of the efforts on an individual basis, provider to provider. So I'll stop there. I could certainly dive deeper, but the final thing I would note for CMS, we cover through Medicaid 40% of the births in this country, which is extraordinary when you think of one program covering that many births, that many women. And so for us, it reminds us that we have a special responsibility. We also have a special opportunity to really impact the lives of millions of women every year. And that is what drives us. That's what helps to inspire us and helps us really to stay grounded and committed throughout all of this. And so I look forward to share more specific examples, but I'll stop there. And just thank you so much again for inviting us to participate today.
Thank you, thank you. And Dr. Hughes, is it 65% for Black women who are pregnant?
Yes, a disproportionate number of those, of the 40%, are Black women.
Okay, thank you very much. I want to start off by just, if we can please just talk about Serena Williams for a minute, because she is the one who really, for a lot of people who didn't know that this was such a crisis for Black women, brought up the discussion. In 2017, her daughter Olympia, she had a normal C-section. She writes about this in Vogue and many other publications. Shortly afterwards, she was short of breath. She went to the nurse, to her practitioners. She had a history of blood clots and suspected that she had a pulmonary embolism. She wanted a blood thinner as well as a CAT scan. The nurse dismissed her, thought she was confused because of the medication. She kept insisting. They ended up doing some ultrasounds on her legs, didn't find anything. She kept insisting again and again what she needed. And finally, they paid attention and they realized that she had those blood clots in her lungs. She had emergency surgery to make sure that it did not go to her heart. And thankfully, she was fine, the baby was fine, and she had 6 weeks of bed rest. So I want to bring it to you, Kanika, because if someone like Serena Williams, really, who has all of the access to the greatest health care and a platform like hers, and they don't pay attention, they don't listen to her, what do we do? You're the filmmaker, what do we do? Where are we with that?
We overthrow the system. No. You know, that's a pretty challenging question because it's a situation where you're like completely powerless. One of the characters, or not, I mean, these are real women, but Shalon Irving, she did all those things. You know, she repeatedly did all those things. She knew her body well. She talked to her physicians, she talked to her nurses, she went back, she didn't look well, you know, and she collapsed at home with her baby in her arms, and she didn't make it out of that. So I think there's times when we really, really advocate for ourselves, and Serena was lucky in the sense that I guess time aligned and someone finally listened to her. But she would have been in that situation as well. I think the other part of this that we don't talk about often is how do we end up in these situations? I found it really interesting in Arlene Geronimus's book about weathering, who coined the term weathering, that really looks at the stressors that Black women experience along their life course and how they get into these situations, which we're pointing out in the film is that the blood clots and the history that Serena had, we don't talk about how she got there, right? So the stressors that she had to deal with as a tennis player, being called gorilla, being called a beast, the racism that she dealt with as a little girl, also growing up in Compton, had physiological effects on her body, right? And so it's not only how we're treated and who listens to us, it's dealing with the impact of racism and oppression that Black women experience in this country from the time we're born. So that's how Serena kind of showed up as well with her condition. So that part kind of gets left out. And it's a two-pronged approach. We can't really solve this issue until we are really solving racism and discrimination in this country and marginalization in this country, because maternal health is not really a health crisis, it's a social crisis with health consequences. And that looks very different. There's no gene for preeclampsia, there's no gene for hemorrhaging or any of these issues that Black women most likely die from. It's issues of stressors and racism that we have to deal with that puts us in these situations. So what we don't want to end up is in these high-risk situations where it's always a watch and wait, because we're not showing up to pregnancy healthy. And so if we don't look at this in its totality of maternal health as a measure of the health of our nation, right? It's a measure of social economic conditions, it's a measure of how we treat each other as a society. And so taking that as a totality, that's how Serena is in her situation. She's someone that has all the resources, but not only was it a toll on her health to get there, even though she's the top athlete, I mean, that girl is amazing, right? The power that she has, right? It shows that she's still not invincible, and she still dealt with all these stressors of racism. Like, I can't imagine being Serena and what they said about her, right? How that affects your body. It affects your body the same way as eating bad, as, you know, not exercising. It has the same physiological effects of your body, those stressors. So with Serena, we're looking at this phenom of a woman that was able to get to where she is. She had some health consequences. She paid a toll for that. And on the flip side, from interpersonal racism, she wasn't listened to, right? So those are the things we have to look at as a whole, and until we are really addressing this issue as a whole, looking at the racism, looking at the interpersonal racism that Black women deal with, we won't be able to solve this crisis.
Dr. Lawson, will you pick up on that? And oh, I'm sorry, go ahead. If you want to jump in, jump in. Sure.
I love this because there's something that Dr. Kamara Jones said during the COVID pandemic that really resonated me. And she was talking with me, and she was talking about the reason why Black people were dying at greater rates. And she said, we are more affected because we are less protected. And I think that is exactly what you're talking about, Dr. Harris, when we're talking about the impact of Black women and why we're seeing these inequities. That's the first thing. The second thing that I think it's worth bearing mention of is this question around self-advocacy, because people ask that a lot, like, how can we teach people to be better advocates for themselves? It is nearly impossible to advocate for yourself in a system that is designed to disempower.
Yeah.
And we have to understand that the medical system is designed to disempower. And so to think that it is a responsibility of an individual then to be able to advocate up in that way doesn't feel realistic to me. The medical system is not the only institution in this country that managed to be uniquely absolved from the legacy of genocide, enslavement, colonization, right? How did we escape that legacy? We didn't. And to your point, Dr. Harris, if we are not willing to interrogate and investigate the legacy and the way that shows up in the care that we provide, especially in obstetric and gynecological care. We can list the names of all of the ways we have violated our communities. And I say we because I am part of that legacy too. It does not do us any service to think that Black doctors are, again, uniquely different from those legacies. We have to unlearn and work and undo anti-Black racism and oppression within ourselves and our medical education and our training as well. So we're seeing reports that show Black women are more likely to survive when they are cared for by Black doctors. Black infants are more likely to survive when they're cared for by Black doctors. But the solution is not going to be to make all the doctors Black, right? The solution is, and you said it jokingly in the beginning, overthrow the system. That's the answer, y'all. That is the answer.
So, Dr. Parrott, what would you suggest in terms of how to change the medical training of those who are in medical school, even at the HBCUs?
Yeah. So medical training is interesting, right? Because it's designed to teach you to forget. To conform. And what the training is designed to teach you to forget is to forget not just who you are, because you have to do that to align yourself with the system, but whose you are. Because if you do not belong to your community, you can do anything. you think about the way that medical education is designed. I grew up here in DC. I went to college for 4 years in Rhode Island. I came back from med school in DC. I went away to Philly for residency, came to Baltimore for fellowship, and then back to DC to practice. That was a small sort of geographical distribution. For many people, it's much greater. There is absolutely no mandate when you move from city to care for people that you learn anything about the community that you're caring for, or the relationship of the people in that community with the institution that has hired you and that is employing you, right? That is the first step. How do we understand that medical education must be grounded in the community? That is the only way. I love the idea of like scaling up projects and programs, but the reality is that everything has to be place-based. There is no way that I can do a program here in DC that is going to be as impactful in the same way that it would be in Baltimore, right? Or in Chicago, or in California. How do we understand that history? How do we understand the legacy? It is our responsibility as healthcare providers, as physicians specifically, because often we hold the most power in these systems to disrupt and to undo that. So medical education is an important part, because people come into medical education and training with those values, the desire to do good. Nobody says after 12 years, I'm about to mess it up. Right? I'm gonna really cause some harm when I get out of here. That's not the goal, right? But this training, it teaches you, it beats it out of you. It forces you to align yourself with a system that has never served our communities, with the hope that one day you might find your way back. And that is no way to enter medical education. That is no way to care for our communities.
Thank you. Dr. Lawson, I want you to address a couple of things, because specifically the skeptics who might be watching on C-SPAN or wherever, or perhaps even in the audience, who don't understand, they don't get the link between racism and childbirth or maternity mortality. They don't understand the social determinants, or what are you talking about? How your implicit bias, how can I be a part of this problem? They might say, I'm not racist. I don't know what you're talking about. How can this be connected? Can you explain?
I love that you asked that question. I've had a couple of scenarios where I really realized the disconnect, right? And so we take some things for granted, being Black folks, being Black doctors, right? So I gave a presentation to a group of legislators, and I finished my maternal presentation. I'm talking about mortality. And the first question from one of the legislators was, are they dying because of sickle cell? No, I didn't talk about sickle cell at all in my presentation. And so I was with the March of Dimes, the CEO of the March of Dimes. She was like, I was at a presentation. Can you believe people don't know? Yes, I can believe it. You cannot take it for granted. In Texas, this past summer, we released our Maternal Morbidity Review Committee report. The chair of the committee produces and discusses the report in an audience primarily of doctors, not Black doctors, just all doctors. And one of the doctors from the back of the room, a doctor, said, are they dying? How many of those women who died were single or were married? And she said, sir, we looked at that too. And so there is a disconnect. We cannot take it for granted. Every space and place you enter, they understand that people are treated differently. I do get it. It's not intentional. I don't think you go to medical school trying to create harm, but there are these things such as bias. I live in a state, you heard me say I'm in Texas. Things even such as implicit bias are being stripped away, right? That is a place for policy intervention right there. I have never thought a 2-hour course on implicit bias was going to resolve the issue and make people not be biased. But at least you can hope that you introduce the idea, right? You begin to expand to people's mind that, oh, maybe I do treat, maybe I do come in with some assumptions about certain populations. I see it most often with our Medicaid clients and patients. There's already an assumption just because of who your payer is, of who you are as a person. So there are all these assumptions that we have to work against. But then when you talk about how do we connect the dots to others, right? And it's just really, I think when you talk about healthcare disparities and equities, it's irrefutable, right? We have so much data. So I'm really looking for action, for collaboration, for education. And I keep saying that because there's still a need. everybody clearly does not still understand this.
Sorry.
Dr. Hughes, I do want to give Dr. Hughes an opportunity here. Medicaid, talk specifically about the policies that are working and those that are not working, and what is the role in terms of Medicaid? Do you see some changes, some initiatives that could really address the disparities?
Sure, that's such an important question. I would mention, well, for those that are less familiar, Medicaid is it's a federal-state partnership. So on the federal level, we can set rules at a high level, but states have tremendous power and decision-making authority in terms of how they're going to implement the program. And so it is a true partnership, and in some states, the partnership works better than in other states in terms of what we're able to accomplish. And I'm not going to call any states on this panel. I'm not going to call any states.
Points in that direction.
But I would say there have been some advances that in recent years that we are quite proud of. And one is in the aftermath, as part of the American Rescue Plan Act, the Congress told us that you can allow states, if they apply for it, if this is what they want to do, to expand coverage to cover a full 12 months after they give birth. And for many states, they only allowed Medicaid coverage to continue for maybe 60 days after birth. And yet we know from the data, we know that many of the bad things that happen to women happen outside of that 2-month period. They need to have continued care throughout the 4th trimester. I'm not an OB, guys. I'm just trying to fake it here. But they want to make sure that coverage continues. And so I'm so proud because as for our internal working group that we had at CMS, we're going to set the target. We're hoping that 10 states will sign up for this, that they can expand coverage. And so just recently, we now have 44 states that have signed up to expand coverage for a full 12 months in a shockingly short period of time. And so I think for all of the efforts, all the discussions that we're having, I know it seems glacier pace and slow and no one's paying attention, but it is resonating with states. States have to have the initiative. They have to ask. And so it is the advocacy. It is working. And we're seeing in our end, and we are able to respond. And there's another thing I would say for Medicaid. Just a few weeks ago, we released the Medicaid health plan rule. And as part in that rule, we have set maximum wait times for women, other patients who need to see, in this case, the maternal health provider. How long must they wait before they can get in? And so it's for primary care, it's also for maternity care, and it also other situations. And so whether it's 10 days for behavioral health, if you need to see a behavioral health provider, as part of the health plan, you have to make sure that they are able to get in within 10 days to see a behavioral health. And that certainly, we think of maternity health and the mental health providers, mental health issues there, that's really important. But they can only wait no more than 15 days if they need to see their primary care doctor or if they need to see maternity care provider as by the health plans. And so we are trying to address access through Medicaid to make sure that women are able to get the care that they need on a more timely basis. So much more needs to be done, certainly, but I do think those are two meaningful steps that I would highlight today.
Can I ask you to follow up to, maybe it's a little wonky, but it's called the Momnibus bill that was introduced in 2021, 12 different standalone bills. This was sponsored by the Black Maternal Health Caucus, most ambitious plan that we have seen legislatively to date to address the issue. Where are we with that? What I understand is we have maybe one of those bills that's been separated out that has gone ahead.
I'm going to defer.
Yeah, it was introduced as a package.
Yes.
And so you're right. There's, my policy friends, there's a structure to it, though, that we have to continue to work with. I mean, I've worked with some of the members on just making sure refinement and what's inside the bill, right, fits from a practice lens clinically. But I recently, in my Senate testimony before the Senate Health Committee a few weeks ago on maternal health disparities, I mentioned perhaps even the Senate considering a twin bill around that. But we have to think about how they're putting it forward and how do we really get passage.
So the thing that's fantastic about the Momnibus, and now we're looking at like Momnibus 2.0, is that it is this really expansive package, right? The challenge and where the rubber meets the roads is during appropriations, and I don't want to be like too wonky around it.
It's okay.
But when we're looking at funding,
a little bit wonky this week.
Right, good. When we're looking at funding for these packages, we often find that Black maternal health, healthcare in general, is the first on the chopping board, right? And so continuing to organize the policy is fantastic in the way that it's written, and we were at the table of the Black Maternal Health Federal Policy Collective, the Black Maternal Health Caucus. Shout out to Representative Underwood and Alma Adams, who have really been leading so much of this work. And a lot of providers were at the table. So we were able to, exactly as Dr. Lawson said, to be able to go in and say, well, what does this legislation look like in real life? None of that matters if it cannot move. Right? And so really making sure that we remain organized, we as the policy folks, we as the healthcare providers, we as those who are invested in the health and well-being of our community, to reach out to your legislators to say, I want you to vote in support of this. So it's not just us on stage that need to be fighting for the Momnibus, it is everyone in community. If you live in DC, like me, we don't have home rule, and so there that goes. But if you live in a state where your vote counts, then it is your responsibility to reach out to your legislators and say, maternal health matters to me, and we want to push this forward.
Absolutely. You said it all, but I will say that a group of us, Black national organizations, reproductive justice organizations, are starting to meet with senators again. We're starting to meet with Senator Butler's office to really help Congresswoman Underwood push this. What do we have to do? What strategies do we need to take? Yes, we got the veterans part of it kind of pushed through, but we need all 14, I think now, bills passed through to make changes, to have the money, to have the resources to really comprehensively address this issue. And you're talking about the bill was so thoughtfully thought out with community members, with Joya, Dr. Joya, and thought leaders, Black thought leaders around the country, Black women that are on the ground addressing this issue, for more midwives, more doulas, more support to really comprehensively address this issue. But the way it just keeps dropping, America is saying, you don't care about Black women, period.
So what do we do? What do, the people in the audience, people who are watching, how do they move that forward?
I think we have to, as Dr. Parrott say, get informed about the bill, see what's happening in your state around the bill, make the calls, put it out there that we need this back and we need to pass this.
It's important to remember that those folks that are sitting not too far away from here down the street are actually your employees. Yes. Right? They work for you. And so holding them accountable is critical. They're not going to move if you don't push them to move, right? And they can't figure out what is critical to you if we are not shouting. So the work that we do at PRH is organizing doctors to show up down there and to say, this legislation matters. We do advocacy days, we show up, we tell our stories, we talk about the implications, each bill, each part of the package one by one, to say, this person that I care for would have had a different outcome. Their circumstances would be shifted if we were able to do that. We also need the voices of those who have been most impacted by this, right? Because the doctors, regardless of whether we're Black or LGBTQ or live in rural communities, we are still operating from places of privilege. We are not the most impacted, right? And so we need all voices at the table to make those demands. There are organizations, if you go to, if you Google the Black Maternal Health Caucus, you'll find the Momnibus package there. You can look up the Momnibus there. It's on Representative Underwood's page to find out more about it. And then also, there are a number of organizations that have information about form letters, right, that you can email. So you don't have to think about, like, what is it that I need to say or what is it that I need to do? You can reach out to those organizations. They have draft letters that you send to your representative. You need to make your voice heard. It is not by coincidence that democracy is under attack when we're seeing worsening health outcomes, right? But we still have the power of the vote, and it's critical that you use it.
Dr. Lawson, I want you to address, there are 3 leading medical causes of preventable maternity mortality in the United States. As you know, you're very familiar with this: blood clots in the lung, hypertension, and blood loss. So can you explain to us why is it that Black women are suffering from these preventable medical causes, more so than their white counterparts? And where do you go? What line direction do you take when it comes to preventable medical causes that are not being addressed?
Certainly. So, and let me just break this down a little bit, okay? Because when you say preventable and you tie those in, so when you are a pregnant woman, no matter what your race is, you're at risk for preeclampsia. Let's be clear, right? It is a condition associated with pregnancy. You stated earlier, and I talk about this often, 58 to 60% of Black women in this country over the age of 21 have some form of cardiovascular disease. Just sit with that for a minute. How many of us have cardiovascular disease, right? And so when you look at one of the top complications of pregnancy-related deaths, it's cardiovascular disease, cardiovascular disease. And so when you look at those other reasons, pulmonary embolism or blood clots in your lungs, thrombosis or embolism, hemorrhage, infection and sepsis is the 4th, right? Those are the top 4 things. All OB-GYNs was all what we're always worried about. And so when you talk about Black women coming into pregnancy, and so that's why I'm a huge advocate of the preconception care. It is so refreshing for me when I get to talk to someone before they're gonna be pregnant. Most of the time, people just show up, right? They've already taken a pregnancy test and they're pregnant, and we work from there. But it's really refreshing. So anytime I'm in an audience and directly facing communities, I advocate for women to pursue that care when you're thinking about getting pregnant, for one, because we want to risk and manage things that you may have pre-existing to optimize your experience in your pregnancy. And so when you talk about also baseline cardiovascular disease, yes, there's going to be some increased risk. And pregnancy in itself, again, no matter who you are, clotting in pregnancy itself is a risk factor for clotting. So that's why it's so important to listen to women, take their concerns seriously, right? And that, because those are things that we, of course, are highly concerned about.
All right, can I offer one other thing?
Yes, and I do want you to talk about the intersectionality between what you were talking about, reproductive justice, the Supreme Court's decision overturning Roe v. Wade, and the health disparities.
Yes, happy to do that. I would say 2 things really quickly about what Dr. Lawson said. Agree 1,000%, plus 1,000. What we're talking about, you know, we're Black women and having a higher likelihood of having cardiovascular disease. I don't want us to think that that's because there's like a gene that we have or because we're broken, right? Harriet Washington writes a lot about the myth of medical distinctiveness, which has been used as a reason to deny care, to experiment, to abuse communities, right? We know most commonly about the Tuskegee experience, but Johns Hopkins and the Kennedy Krieger Institute was also involved, right, with the lead paint study in Baltimore. And so these legacies, they live on, and they are undergirded by this myth that disease presents uniquely different because of your race. Right? And that is what gets us in trouble. So yes, we have a higher risk of cardiovascular disease. Yes, we are less protected, and as a result, we are more affected, not because we are broken. The other thing that I want to say about, you know, the challenge, I agree with you, like it is wonderful to be able to see people before preconception care, and poverty and racism makes you very preoccupied with survival. And so the idea that folks can, from communities that have been divested from, underinvested in, and marginalized, will be planning these pregnancies in this way is not one that rings true through the research when we talk to pregnant women and birthing people. And so that's important to keep in mind. If you can get in, absolutely. And what do we do with the circumstances that we're confronted with now, and how we navigate that and help our communities navigate that when preconception care is not a possibility? To answer the question that you actually asked me.
So
Briefly, yes. So I think it's really critical to think about this intersection. Well, the reason why I mentioned reproductive justice is because abortion is part of that. There are 2 big cases before the Supreme Court now. One is looking at the use of a medication abortion pill called mifepristone. and whether or not the FDA approval process was in line with medical evidence and science. Spoiler alert, it was. Right. This is not about medicine, it's not about science. The second one is EMTALA. This is your right to actually get medical treatment when you show up to the hospital, right? If you are bleeding during pregnancy, you're having a pregnancy loss, you're having an abortion or showing up in the hospital. What this case is saying is that these hospitals can turn you away. They do not have to provide life-saving care. We know that abortion bans, these are just the two cases, but abortion bans have been sweeping the United States for the last 50 years since the passage of Roe, up to and including 3 years after Roe was passed, 2 years after with the Hyde Amendment. I'm not pointing at you, you ain't passed the Hyde Amendment, but the government, right? That's in the Hyde Amendment, right? Not Congress, right? That's not you, right? But thinking about, access to reproductive rights has been under attack from the beginning. It was not an issue because the only people that were impacted were poor women, right? The only people that impacted were women of color. The only people that impacted were people in rural communities. So understanding that our struggle for birth justice has to be connected to our struggle for reproductive rights. Our ability to make autonomous decisions about our bodies includes the ability to decide if, when, and how you build your family. And that will always include abortion.
I want Dr. Harris to weigh in. Put your doula hat on for a minute. There's a 2023 abstract, and it says that while overall infant death rates have declined since the 19th century, the disparity in death rates between black and white infants is greater today than it was under pre-war slavery. Can you explain what you're seeing as a doula? And then we're going to open it up to a couple of questions in the audience.
Yeah, I mean, what we're seeing is a disconnect between, you said it earlier, birth doesn't happen in a vacuum, right? Birth is a backdrop of social, political, economic, community. That's how birth happens. Birth happens in community. So when you see these numbers, what you're seeing is a disconnect in investment and trust and love and connection, right? And community and family and all of those things. You can't just, well, this is what we do. You walk in and you see your doctor, you have no connection to that doctor has no connection to your community, but birth is just not physiological. It's all the things that are happening in your family and in your community. You're literally birthing community. So when we have taken midwifery away in that midwifery model, those midwives really usher in and steward community. They're gonna say, hey, how you doing? Hey, you don't look so good. How's your sister? Did you know it was this program over here? And so you're feeling connected and loved in that birth process. So maybe your circumstances may be pretty bad because back way then, I mean, we didn't have all the technologies, resources that we have now. Poor then looks nothing like poor now, but the birth outcomes were better, right? And that's because we were birthing in trust, love, intimacy, all those things that we think don't matter. They absolutely matter. And when you think about it, I'm Native Washingtonian, where when in that maternal mortality committee was, we make up black women, well, black people in DC make up 50% of the population, but 90% of the deaths, right? In Washington, DC. And we're seeing this gentrification. When I grew up in DC, it was all black. Yeah. We had the black schools, we had the black grocery stores, we had black businesses. The birth outcomes were so much better then. So it's really about, when we're talking about overthrowing the system, I really think that it's not really about segregation, but it's really about how do all communities get access to the same amount of resources to do with them what they need to do. That's just not hospitals, and it's just not clinics and healthcare. That's not it. If you think about it just from that level, you're missing the mark. It's your schools, it's your grocery stores, it's your communities, and how do you have the power to infuse what you need into that? And that's true justice, and that's what you're seeing in terms of the difference between then and now.
I'm going to open it up really quickly if there are any questions from the audience. Yes, just go ahead. You have a microphone there. Oh, sorry. There you go.
Hi again. My name is Lakita, and I am a retired nurse from the Air Force. And so this has been my work for the last 7 years. And so I want to address the Sabrina piece because as a nurse, I believe I would have recognized that she was having a PE. For an example, I do in-home visits. I go to the mothers, like the young lady in the middle, Dr. Harris, and she was mentioning, you have to ask the patient, how they're doing and everything. So my question would be, what are we doing to not just address the access, but the availability? So we have a whole bunch of clinics, hospitals that are closing. And so just because by name we have access to a prenatal clinic, but these providers are being squeezed and they no longer have availability.
So I think you bring up an important point. I was hoping we would bring that up today. You're right. All of the hospital closures, there's a lot of closures, and people are pointing to a lot of different reasons. And so workforce is a piece of that. Many of these hospital closures are purely based on they don't have the staff. I live in Dallas downtown. We've had multiple hospitals either close labor and delivery units or close altogether. So I agree with you. Much of my work this year has been on increasing workforce. In my regular full-time job, it's focused on increasing workforce. We just resourced an HBCU where we're training doulas, midwives, and lactation consultants. And so that is going back into community and making some demands in community, right? Through community-based organizations, resourcing them so they can expand programming. And so that is something we all have to think about. But you're absolutely right. It's an access issue, an availability issue. We can create programs and talk about this, and I don't even like talking about the numbers anymore, right? It's about what are we going to do.
Let's take another question really quickly, and then we'll have to wrap. Is there anybody else who has a question? In the middle there?
I think her up there first. You're closer to her. Just go ahead, yeah.
Thank you. Hi, I'm Valerie Rochester. I'm with Creating Healthier Communities. And I had a question. We're talking about doulas, which of course are a significant part of the healthcare workforce, but the reimbursement rate, the Medicaid reimbursement rate for doulas is abysmal. And I think we work with a program where we are really uplifting the work of doulas, and we support funding to ensure that they have a livable wage so that they don't have to take 2 and 3 other jobs just to make a living. But just wanted to see if there is any effort underway to ensure that there's some consistency across the Medicaid doula reimbursement rate. My home state of Indiana, which I left many years ago for many reasons, has a Medicaid reimbursement rate of $18 a day. And that's just ridiculous. So just wanted to see if there are any efforts underway to take a look at that.
Dr. Hughes.
Yeah, thank you for that question. We are very much focused on that issue. It's been brought to our attention. It does become difficult, again, for the reasons I mentioned, back to that federal-state partnership. We can't tell states how much they have to pay, how much they have to reimburse under Medicaid, but we can, in other ways, we're exploring how we can strongly encourage. And I think as one example of that, we also recently announced this is in the context of Medicaid providing home and community-based services, that states, through their Medicaid program, they have to provide 80% of the Medicaid payments for home and community-based services have to be passed through to those that are actually providing the home and community-based services, and in many cases, obviously, direct care workers. And so I think just trying to think through creatively what are some of the ways that the federal government can encourage, push states to provide a reasonable wage, and we know that many states were so far from that. So I do appreciate the question, and be assured that that is an issue that we're looking at.
And I would just add to that, because that's one of the other projects I'm working on, is doula reimbursement. For those, there's really only one state, Rhode Island, that mandates commercial payers pay for doulas. And then on the Medicaid, I'm looking at those numbers. One of my concerns also, in my area, doulas, I've worked with doulas for 20 years. It is nothing new. It's been cash pay. I know they charge several thousand. It's just an issue of, with Medicaid, are they equipped with the billing knowledge? Because they've been cash pay. And so looking at the increment, so I'm looking at maybe some curriculum to help doulas and the business model of billing. And I'll talk to you offline about that if you like.
And I think Maya's looking at me like, you got one more? Okay, go ahead.
Thank you. I just appreciate the local context that you provided with DC as an example. Can we expand globally and see if there are other countries predominantly that have Black and brown people that have positive maternal health outcomes, one of which I can think of immediately is Cuba.
Yeah.
With the resources that they have, but the mortality and the lack of immortality that they have. And then secondly, only if you feel safe and comfortable, is recently with all the genocides that are happening globally that are impacting Black and brown women, what connections does this work have with them?
Sure, Cuba, I'm gonna let you answer the second part. I just got back from Cuba, so that's why I wanted to jump in. I got an advanced certificate in maternal health at the medical school in Cuba, looking at the medical system. And what I can say about Cuba is it's a whole nother world, right? They have literally no resources because there's been a ban since the 60s, since forever. And, but the doctors have to not only live in the community, they live in the building, and they stay in that building with their patients throughout their lifetime. And, you know, they have maternity houses, so anyone that's high risk, you stay in a maternity house, and your doctor travels to you in that maternity house in community with other women until that baby is born. I saw one apartment building that was so amazing to me. It was a huge apartment building, but they also knew all the health conditions that happened in that apartment building. So if it was diabetes, if it was heart disease, whatever it was, they knew the prevalence. And then there was a garden next to the apartment building to address those issues for that community, right? And when the baby comes, there's a doctor that lives in the building for the baby. So, I mean, it's just a different comprehensive way of thinking about health. And you can see, again, with your example that you gave about history then versus history now, even when you're denied resources, you're denied healthcare, you're denied supplies, the hospitals in Cuba are not great. I'm not by any stretch of the imagination saying this is like your dream place, but they've been able to keep their numbers low, and there's accountability. A baby dies, somebody's head is rolling. A mom dies, somebody's head is rolling in Cuba. And so there's a high level of accountability, and it is a community model. And so with so little resources, you know, we can figure it out and we can get it done, but the power has to be given back to the community and those folks that know what to do, what they need to do. And we can't wait for that, right? We're not giving permission right now to save our own lives. We're going to figure that out for ourselves.
Dr. Parrott, you're going to have the last word because we've run out of time. And
Okay.
I have the final question I had hoped to get to everybody, but what keeps you up at night? And what is the one thing that you would change to rectify that?
I have to answer that, or you want me to answer that?
Answer that one.
Answer that one. Okay. So many things keep me up at night. I mean, I haven't slept well in 45 years. I think, you know, the thing that worries me most is really the state of reproductive rights and the impact that it's going to have specifically on Black women and birthing people and people with the capacity for pregnancy. You know, we know that abortion bans result in an increased risk of maternal mortality. We know that there are certain communities that will continue to be left out of the cold and in the cold. And the thing that worries me most is that it's not simply about eliminating access to this one piece of care, but the desire is to criminalize, to jail, and to punish people who make decisions about their bodies and their lives that are not aligned with the dominant culture. People who are making these decisions when their fertility is devalued. And until we're really ready to engage with the risk of criminalizations that our communities have always faced and will continue to face, then we are going to continue to see more Black and brown pregnant people being jailed, arrested, and interrogated. If you are, this is super quickly a resource for folks who are watching, if you show up to the hospital, you're experiencing pregnancy loss, you have access to abortion outside the routine medical system, and you are being questioned, if you are being arrested for suspicion of managing your own abortion, please reach out to the legal helpline at If When How, Lawyering for Reproductive Justice. They have bail funds, they have lawyers, pro bono lawyer support. The risk of criminalization for pregnant people for their pregnancy outcomes keeps me up at night and will continue to be infinitely worse.
Thank you, doctors, sisters, experts, for this amazing conversation. Thank you so much. We're going to do a fireside chat, but we're going to hear from our MC. Yes, yes, okay.
As we're getting ready for a picture, I just want to say thank you all to this amazing panel. And the great thing about living in the now is that we have technology. And if you're on Twitter, I think it's called X now, you can use the hashtag Hope Challenge, and we can keep this conversation going because it was so rich, and I think we could have went for like another hour, 2 hour, and came up with policies and solutions and funders and all these great things. So let's keep this conversation going. In the meantime, we're gonna have a 7-minute break, so please feel free to go out, stretch your legs, get up, and then we'll come back here for our fireside chat. Thank you so much.
My name is Dr. Ebony Marcel. I am a certified nurse midwife. I am the director of midwifery at Community of Hope here in Washington, D.C., where we provide the most amazing prenatal care. Today we are at our lovely birth center. We do have 3 sites that we see patients, but this site is really special because it has our lovely birth center. I see my role as a midwife really layered in a reproductive justice framework, social justice, really focused on trying to take care of under-resourced Black families. You know, we have been here since the beginning of time. I like to say that we're the 2nd oldest profession. We take care of birthing persons pretty much through their entire reproductive lifespan. So starting with GYN care, we also do prenatal, pregnancy, postpartum. I support maternal mental health by making sure that I'm providing good holistic care, not really just focused on just the pregnancy, but also the whole person. And we ask questions like, what's going on at home? What's the plan for support? So we try to take care of the birthing person through their whole entire spectrum. It's hard work, but it's so rewarding, and it's so very important. I think one of the things that really helps me on the days that are really hard and challenging, not only like a beautiful birth that is really lovely, but also my team. My team is really passionate, and they're also just loving and supportive as we're doing this hard work. As a midwife for 13 years before I had a baby, what an experience it was to finally be on the other side of the fence. And I had my daughter, my husband caught her, and I was, you know, able to have everybody in the room that I wanted in the room. And I just will never forget the joy of, you know, when after I delivered standing up, and, you know, my husband and the midwife passing my daughter to me, and that first look, it's indescribable. I love the fact that I feel like I'm becoming more impactful in what the scene looks like, especially around Black maternal health. What's given me hope about Black maternal health equity is just seeing more people on the movement. And I think I'm just really proud that we're starting to kind of shift. We still got work to do. But we're at least starting to kind of shift the narrative and like change outcomes. My hope for Black maternal health is that there's continued awareness, that there's continued efforts and support in trying to change outcomes for Black birthing families. We are coming together to support Black families before, during, and after birth. It's time for us to be seen. It's time for our stories to be heard. Join us. Shine a light on Black birthing stories of hope.
Welcome to the Nurture Her series, where we're supporting Black families before, during, and after birth.
My name is Jamila Muhammad. I'm a Healthy Start doula here at Community of Hope and a native Washingtonian. I'm proud to work here and support women in DC. The work I did before becoming a Community of Hope doula, I worked as a perinatal care coordinator, and I supported the families that were in our homelessness prevention program. And so we worked to kind of help families that were unhoused and pregnant ensure that they got the care that they needed to have a healthy and successful birth. When thinking through the healthcare system and focusing on folks that are unhoused, it's important to realize that they have so many competing factors that it can be hard for them to really focus on their healthcare and all they need. I work primarily with folks that are pregnant, and as much as they want to ensure that they have a healthy pregnancy, when they are unhoused, there are many other factors that kind of come before taking care of their pregnancy and attending regular prenatal appointments. So part of what my role is to help support them in focusing on the health factors, and then their housing case managers support them in securing housing. The holistic approach to healthcare works the best because it takes into account all the things in a person's life that can impact their health. A lot of times in the medical setting, we just kind of focus on data and numbers. But when you look at the whole person and their social life, their home environment, even their past history, it helps you inform you better about how to care for the whole person. The work that I did actually kind of helped to feed me as well as a person that was experiencing pregnancy. It was just an unspoken connection. Like, we are experiencing these similar things at a similar time, and I'm able to support you. My birth story of hope, my last pregnancy, it was a bit of a high-risk pregnancy, but kind of having the support of my community and family and the work that I did kind of really helped me feel like I had the strength to make it through. And I had a beautiful baby boy born full term, which was a first for me. So it was a wonderful experience. I think the thing that was most helpful to me, and another colleague in the birth space shared this with me, take the time to grieve the birth that you wanted and then embrace the joy in the birth that you had. Like, find the silver linings and all the things that you experienced. The most rewarding part about being a doula is the satisfaction that families have with their birth outcomes. Things can be challenging in the world we live in when it comes to birth, especially with families that are Black. And so being there to help them advocate and have the birth that they dreamed of is what kind of gets me out of bed every day. I think with my role at Community of Hope, as well as the work I do in the community, helping to support other doulas, it's kind of shining a light on the work that we do and the ways that we can support improvement in the maternal health crisis that we're currently experiencing. Doulas are one of the ways that a lot of studies have shown can improve the rates for Black birthing people. What's giving me hope about the future of Black maternal health equity is the number of people of color that are getting into the work. When your providers look like you have better outcomes. And so to see so many Black and brown people choosing this as a career path gives me hope that things will look different in the future.
So just have it standing up here. Maya. Hey,
guys to do. Okay. All right, everybody. Thank you so much for sticking around for the fireside chat for our second half of this wonderful discussion, and thank you so much for being here. We are now moving from the data and the policy focus into the experience and practice realm. In light of the challenges receiving quality care in hospital settings, women of color across the country are exploring alternative settings, as well as imagining alternative futures where it is possible for all women to give birth in safety to healthy children. It is my honor and delight to welcome our fireside chat panelists. They are pioneering women who are really doing the work that is necessary to make change, to make real change. So let me go ahead and introduce them, and we'll get right to the chat since I know our time is a little bit tight. Dr. Joya Creer-Perry, a renowned obstetrician, gynecologist, and the founder of the National Birth Equity Collaborative. Dr. Creer-Perry is a leading voice in the fight for health equity and has dedicated her career to addressing racial disparities in maternal and infant health. Dr. Creer-Perry. Dr. Lauren Parker, who is also our MC today, who also shared her own personal story in one of those videos you saw. She is a distinguished researcher and associate scientist at Johns Hopkins University. Dr. Parker's work focuses on the social determinants of health and the development of community-based interventions to improve health outcomes for Black women and their families. Dr. Parker. And Ms. Linda Wilson, a passionate advocate and leader at the Fund to Foundation. Ms. Wilson's efforts are instrumental in supporting initiatives that empower Black women and promote health equity through innovative funding and community engagement. Ms. Linda Wilson. Okay. All right, thank you so much, everybody, for being here with us. I want to start off. This is more of an informal conversation, more of a chat. Really, we can go anywhere where we want. So feel free. I want to start off maybe just talking about a little bit about the distrust that so many Black women feel when they go to the hospital, when they see their doctors, that in some ways can prohibit them, right, from asking those important questions, or maybe just deciding that they're not going to go. How do we get over that when we hear the stories about Beyonce's pregnancy, right, and Serena Williams' pregnancy, and they're not paid attention to, they're ignored, and these are successful, highly educated people. Where do we begin there, the distrust?
Good morning. Okay, it's on. Hey, y'all, how y'all feeling? Everybody's good? Yeah. Yeah, it's on. I just got to eat it a little bit more. So I would love to talk about the mistrust, because when we did interviews with Black birthing people across the country, my organization did, to ask them when they think about respectful maternity care, which is a term that was coined by the WHO, and we usually think of it for like lower resource countries, like what do they want? And what they want is a trust-building appointment with a provider. So just think of that. Like, I assume if you called and made an appointment with Dr. Joya that you trust me because you made an appointment. Turns out the patients are like, not so much. We would like for us to sit down and see you as an actual human being. We want you to actually talk to us. We want to know about your family too. We don't even think of medicine and healthcare in that way. It was totally mind-blowing for me to really actually listen to the patients and say, oh, they want to know that we're human. We're not a robot. They want us to be trustworthy. So we have to then reimagine how we even enter conversations with patients to say they don't trust us, and they want us to build a trusting relationship, which requires us to let down our guard, which requires us to actually talk about things that are happening in our lives. This is the opposite of how we are trained. To Dr. Parrott's point earlier, we are trained to dehumanize ourselves and to act like a robot. And that is the opposite of how you build trust.
So when they come to you, do you give them that time? I can't imagine doctors doing that.
Well, so for me, because I practiced in New Orleans, so everybody thought they were my friends. So like, I would get invited to everybody's baby shower.
So I understand.
So, I understand baby showers. I was my daughter. Did not survive teenagehood. Like everywhere she would go, people would say, "Oh, that's Dr. Joya's daughter." She couldn't go out on a date. Like, you know. So yes,
I know New Orleans.
You know, so yes, it's easier when you're of the community. People see you. People thought of me as like their friend, and they would even introduce me to their friends and say, "Oh, this is the nurse that delivered my baby," which I never took offense to, because for them, they just thought I was a trusted person who they loved and cared for, who they invited to all their things. I have so many pictures and books of all these babies. So it is, the truth is, we do not pick physicians because of their trustworthiness. We pick them because they can pass tests. We pick them because they've done research. We don't do anything about personality evaluations to see if they have a personality disorder. Like, none of that happens, y'all. So we have a whole bunch of people who are physicians who are like, think they can be a robot. And for birth, maybe for ophthalmology, my dad's an eye surgeon. So for ophthalmology, you know, you need somebody who can just look through a microscope. For birthing, I'm gonna need to trust you. I'm gonna need to know that you're human, that you're of the community, that you value me, that you think that I should be here, that you see Black folks in the future.
So what if you're in a hospital setting, right? And I know I'm not supposed to bring up all the stats and all that, but I do have a couple, right? Because it says 30% Black Hispanic women in the United States, they deliver in a hospital, they feel mistreated by the staff, the practitioners. And a survey in California, Black women 10 times more likely to report mistreatment in a hospital when they are giving birth. So does that change? Does something change when Black women enter the hospital setting and people don't see them the way they are anymore? Or what is the solution?
Well, that's a great question. So when I gave birth in Baltimore, right? And so we know Baltimore is a very populated with a lot of Black people. And so my physician, she was actually a Black woman. And so it's interesting thinking about trust, and I want to go back to that and answer your other question. I had a trusted relationship with my OBGYN for about 4 years. So I think another part of trust is it takes time, right? And so for me, I'm really glad that I was already integrated into the healthcare system and I had this trusted relationship. And to be honest, I told my OBGYN, I said, I see all these stats about going to the the hospital, and I'm concerned about going to the hospital, so I'm going to find a midwife to have a home birth. And she said, okay, do what you want to do. And so I actually interviewed like several midwives, and going back to that trust factor, when I was interviewing them, they were very kind and nice, and they actually looked like me and think about racial concordance, but having that trusted relationship with my OBGYN made the most difference because I knew her for 4 years. She's been with me pre-pregnancy, after pregnancy, and so that was really important. And so for me going into the hospital, because I had that trusted relationship, I took her advice because I was thinking, I'm gonna have an all-natural birth. I know all the positions, I'm doing everything right, and I had to make a decision to have a C-section. And I do think that if it weren't having that trusted relationship with her, I probably would have fought this system, right? Because I'm like, you only want me to have a C-section because it's 5 o'clock, you want me to have this baby really fast, you wanna go home to your family, it's around the holidays, my baby was born around Christmas. And so I think having that trusted relationship is so important because I think it helps you feel more calm and at ease when you're going into a system when you're already thinking about all of these stats that show that hospitals might not always be in favor of Black women, but it helped me calm down. So I really value that.
Ms. Wilson, you and I spoke before, and I don't know if you'd like to share it, but you talked about your own pregnancy and how you felt that your circumstance was just as bad as what Black women are going through today, and you called it criminal. Can you get into that for us, if you would?
Yeah, is it on? Okay.
Yes.
So I'm an old lady, so and I have a daughter that's 53 years old. So if you think about it, my first birth was quite a while back. I happened to be a single mother at the time on Medicaid, and the way that I was treated was just horrendous. And I'll even mention the place. It was Georgetown University. And as a Reformed Catholic, I thought I would have been treated a whole lot better. But the things that actually happened that day were disgusting, and to the point where I was in labor for 72 hours, and actually was told as I finally was being wheeled off to have the baby, that I was loud, I was very loud. And happened to be in the Black Panther Party at the time, so I was a little bit combative. So I
have a feeling there's a whole other story, a whole other layer around this.
Well, they definitely want me to tell about how Huey Newton called me. But anyway, the point is the nurse who happened to be pregnant told me, if you're going to scream this loud, then you should have thought about that when you were lying down making that baby. I think I reached up like the exorcist, and the filth that came out of my mouth, I'm very not proud to say. But what happened was she was actually, my daughter was turned around improperly, and I was later told by the pediatrician that it was birth trauma, that my contractions choked her, and that she was born dead, and they were about to put her away, and and she took a breath. And so they, did not allow me to see her for 3 days. I was acting a complete idiot by that time. And the nurses had the nerve to come to me and say, well, she's just mean. How is a newborn mean? I mean, I really should have sued if you think about it, but I'm not litigious. I'm a fighter. I'll get you other ways. Right. But literally, when I went down finally to see her, and I put my hands through the little, what is that? Incubator? Yeah, the incubator, thank you. She literally turned to me and smiled. And I knew then that they did not know what they were talking about. They said she would die in a month, she was mentally retarded, or she would, all kinds of things, and they gave me phenobarbital to take her home. Anyway, she had seizures for a few weeks, and one day I just got upset and threw the phenobarbital against the wall. She didn't have a seizure ever since. Right. My point is, when you bring up trust, in order to trust anybody, there are 3 elements. Number 1 is reliability, and you all talked about availability. And I need to know that what you say you're going to do, you're going to do. And that's what the physician mantra is, to do no harm, number 1, and to care for you. The next thing is competence. And I literally, with my third birth, had incompetence too. So I mean, the more births you have, the more chances you're going to have some trouble, whether you like it or not. And the third piece is authenticity, and that's what I hear a lot. You need those three elements to have true trust in any relationship, and I don't feel that I had that. I mean, it seemed like they were still operating from that whole women's thing about hysteria. You must be hysterical. Remember, they put people away for that. And just to bring back to the Huey Newton thing, I know you like this thing. He had the nerve to call me because I was still acting up in the hospital, and said, "Comrade, sister, you need to act better. Don't be embarrassing."
Ability politics from.
Oh my God!
Look, and you know you can have another baby.
Oh my goodness! Oh my goodness! So you're getting from all ends. Why?
That's the point.
You compared it also though, but the second part of the conversation was that you said that women today are going through the same kind of trauma that you went through. How so? Explain that.
Well, you know, even with our own selves, I mean, we still have that male model of linear care and not holistic care. And I see that even today. I mean, I'm in the geriatric world now, and it's like, I do have to act like a yard dog to get attention all the time, you know. But I do hear of things, you know, especially if you are not a combative person, where you have to advocate, that I heard the other women talking about it. You don't really want to have to act up all the time. But people should really listen in a care way. And I'll tell you another thing. I'm weary, quite frankly, always putting myself out to get people to give me good service. Do you all know what I'm talking about? Where it's like, I got to cajole you. I got to befriend you. I just really want a little more competence coming my way as a human being, both ways. So I see that because I go with my granddaughter, I go with my daughter, I go with other people, and I still see the very same, you know, just not, I don't, and let me give them grace, because I know people are overwhelmed. Right. Even my Black female doctors, they're like, I got 20 minutes, I gotta go, you know, also the baby needs to be picked up. It's like a lot. So I just am so sad that at my trimester of life that I'm still witnessing that people are going through the same things.
I noticed that several of you talked about having Black doctors, and it's interesting, right? Because when I grew up, my father was a physician, so all of his friends, his buddies in the world of Howard and Morehouse and Meharry, all my doctors were Black, and so I, you know, as a kid, thought all doctors were Black, you know, until college, and I had my first white doctor. So, but now we look at the statistics, and it's like, okay, Black population is 13%, 5% Black doctors out of the whole pool, and even less, 2% Black female doctors. So what do we do with that, right? I mean, should our focus be in training and bringing up our people, our physicians, or do we have to retrain everybody else who maybe is not understanding what we're going through?
I mean, I do think so. These conversations are tied. So these structures were built and created to support a white middle class. Like that, the healthcare system in general is created to build it. So that means the physician workforce is supposed to support a white middle class. In fact, even the research, they use a 70-kilo white male is like your standard for any research. So this idea that any drug or anything that you're on is based upon kind of there being a white-centeredness. I'm trying not to use too much I love advocacy language. But so when you create a system around whiteness, then you do all these things like not invest in ensuring that there are Black physicians. You do things like get rid of programs that were pipeline programs from elementary, middle, high school, and college to ensure that there were Black physicians. There are fewer Black males in medical school now than there were when our fathers were. I mean, in the 70s, right? So like that is because the structures and the system does not value having Black providers and Black systems. So we have to say, we want to be able to walk into a hospital or a home birth and feel safe. We have to say, how do we create restructure the entire system that says we want to invest in pipeline programs from elementary school through college. We want that we see the numbers, that there are fewer black men in medical school today than there were in the 1970s. Like, that should not exist. That should not be. And then the data around people feeling mistreated when they go in the hospitals, the reason they feel mistreated is there's fewer of them. Doctors, black doctors, even though we're overworked and running around looking crazy, we are physically an interrupter of harm. Like, when we are on a labor and delivery unit or in a ICU or I make my parents call me on FaceTime when they go to a doctor's appointment, because I don't trust everything that's going to come out of the provider's mouth, and I need to also be aware of what's happening with them. I've been through many things with them in ICUs and hospitals, so it's not just birthing. The entire structure of this healthcare system is based upon supporting a white middle class. So once you let that sit on your spirit, say, well, what would we need? Like, what would I need if I say I want a doctor that knows me, that comes from my community? Then I need you to then, from elementary school, have people in Anacostia learning about medical school. What are we doing to ensure that we build a workforce that looks like the actual community?
Yeah, I really appreciate that comment. I was also thinking about bringing in the community, right? Like, having the physician there is just one part of the birthing process, but thinking about before you're pregnant, thinking about lactation consultants, people who helping with breastfeeding, that's an integral part of pregnancy and after having the baby, and also good for the life course of the child and also for the mother as well. And thinking about doulas and the importance of that role, but bringing in those different pieces of community who are all integral to the birthing process and after baby is here and making sure that mom is okay is so important. And I also think that having all of those members who are at the table with the physicians, taking away that power structure. So teaching physicians how to work with these other key components in the community to make sure that everyone is happy, healthy, and whole after the baby is here, and also that mom is well afterwards as well.
What is the reception of the doulas and the midwives today when you're in a hospital setting?
I mean, if it's a really nice doctor, like Dr. Lawson, it's great. When you have someone who says, I've been working with doulas for 20 years, it's great. It can be competitive. I usually try to give this example. One of my very bougie black friends in New York City was pregnant, and her provider was one of our other bougie black friends, who's another doctor in New York. And so when she said to our friend that she wanted to go natural, the first thing that the doctor said is, oh, you need a doula. So that made me be acutely aware that when we think people are valuable, we say you should have a doula. If you are under-resourced or low-resourced, they think of doulas as a competition, someone there to fight you. It's just a very different dynamic. So I just remind my provider, my OBGYN friends, that you all, when it's someone who you value, you want them to have the social support. You want them to have somebody there to help them burn the sage if they want to burn sage. But if you think that the person is low-resourced or not deserving of support, and it doesn't have to even be, it's not an active thought. So bias is implicit in our minds, right? So like I did the implicit bias test, the Harvard one online, it's free. I'm biased against old white men. I know y'all are shocked by that. But, so like I want you to understand.
They have tests.
They have tests. They do. They literally. Okay. It's free if you go on the Harvard Implicit Association. I have an ageism, and I'm not so good with white folks. So that's just the truth. So I have to know that about myself. So I lean into having more conversations with older white gentlemen to work on my bias. I'm offering that white folks can lean into talking to low-resource black and brown communities to decrease their bias. Because when you show up as a provider with your bias, you actually can kill us when you have these assumptions about our hypertension or what we have at our houses. So that's it.
Home birth.
Yes.
So that is an alternative, and that's an alternative that more and more black women are seeking.
And white women.
And white women, yes. A statistic that 2019, 2020, that the rate of those black women opting out of hospital births, it increased by 36%. So what is the recommendation here? I mean, you're talking about, when we talk about black women, we talk about a lot of high-risk pregnancies. What the pros, the cons of having a home birth?
So I could talk from my personal experience because I had a baby in 2022.
Please do.
And so when I was speaking with my OGO and I let her know I really want to have a home birth, and she was saying to me, I was over 35, and so she was like, "You're a geriatric." I was geriatric too.
We're all geriatric.
You're a geriatric mom, and so that kind of hurt my feelings. I was like, I feel like I'm still young and cute, and I am, but
you still are. You got it.
But thinking about those risks, right? And so I am a woman. My BMI was over the recommended level, right? So all of these little indicators is why my my Black OBGYN was like, you know, I really don't recommend it. And she had her own bias as well. And she admitted that, and I appreciated it. And she said, I'm also open to exploring and work with you until you make a decision, and I'll be here for you. So I appreciated that we could have those conversations. But again, we've been together for 4 years. But for me, when I was going and trying to interview these midwives, they were very lovely and nice, but the reimbursement rates. And so for me, I was thinking, okay, I need to get ready. This is my first baby. I need to get the crib ready. I need to get my house ready. I need to get my mind ready. I need to tell my job, I can't do this research stuff anymore. And then I was like, and then I have to call my insurance company and try to figure out, how do I get these reimbursements for these midwives? And that right there was so stressful. I really wanted the home birth burning sage instance, having all the candles, all the cute things in the pictures, right? But for me, it was really about the reimbursement that really made me pause, because I just didn't have the mental wherewithal to go through it. And then, you know, thinking about now that I've been through the 4th trimester, I don't even think that I would have been mentally aware to make sure that I had all the paperwork together to fill that back in. So for me, that was a barrier for doing something that I really desired to do, which was to have a home birth.
And that's what we talked about the last panel, right? Where some of those barriers to actually doing what you'd like to do. Go ahead.
No, so the National Academies of Medicine has done a whole series on this, and I got to the privilege of being a part of it. So the United States is the only industrialized nation that does not support home birth. Every other country, there's an actual system and structure for it. So part of the reason we have poor outcomes is because we don't support it. When you act like it's the same thing, honestly, we do with abortion care, to be honest with you. So when you pretend like it's a side thing, mental health care, we do the same thing. So when you don't include it in your actual system and structure, so you would do things like know that someone's going to have a home birth and plan for it. So you would have availability of an ambulance in case there's an emergency. They would have their records already at the hospital. When I covered the home birth midwives in New Orleans, they had to pretend to be doulas. And they'd have to come in, and they have to act like, oh, I was just, it was such a silly, it creates increases.
What happened? I don't understand that.
So because people don't really allow for home birth in New Orleans, it's not culturally, the nurses, they wouldn't necessarily go to jail, the midwives who were doing the home births, but it was not a common thing to happen. So I supported them. So the patients would see me on their insurance, and they would pay the midwife, who was the home birth midwife, cash or whatever they were doing, and they would see me as a regular provider. And then if there was a complication during the home birth, they would bring the patient in, but then they would have to pretend that they were just the doula supporting the patient. So that level, and so abortion is the stigma of like when you have to pretend a thing is not really happening and act as if you are just there as a doula, you create a stigma that does not have to exist. So the reason that, and then during COVID, the reason I said white women too is because in places like New York, all these white women took over all the home birth spots, right? So like so many black women have been using kind of the indigenous midwives in the community, and they got taken over. So privilege is a real thing when you have access to the cash to not worry about the reimbursement from your insurance company. So that's a structural CMS health insurance issue as well. So if we could just imagine that people have the ability to make decisions for themselves, and that if they want to have a home birth, it is not your job to tell them that it's bad or good. It is your job to just say, hey, investigate that, which is what your provider did. And then we create a system that allows people to have home birth, birth center births, or hospital births, whichever they choose, and that they're supported financially, emotionally, and spiritually. We would have much better births.
Ms. Wilson, you had something to say.
I don't even, I get so much into what people are saying, I forget what I was thinking about. But I will say that something that I noticed when we were at a, what was it, the mom's, oh God, what was it? We went on a tour, a mom's tour, and there were a lot of women who were there, and they actually pulled from, the community. And what I realized is that there was a lot of talking over people's heads about what it was, and that the desire, and I happened to sit in the overflow part where, you had the tables and the children were running around, and it's kind of hard to listen to stuff when you're like, come back here. But what I noticed was a lady, a young woman who was pregnant behind me. She said, well, what really does a doula do? And so I happen to, I know something, right? I'm the only undoctored on here, but I turned around and I said, well, there's a lady over there that can really tell you how to do it. And then we had a conversation, and what I learned is that you have to have a longer conversation about life matters, and she was, when she got into it, and I told her, oh, well, they even have free availability for certain things. And then I walked her over there and everything. She would consider a home birth. She hadn't even, it was not even on her mind. But we do have to stop talking over people's heads so that they can understand it and really, I just keep thinking back to when I was at SNCC and CORE, even though I thought I was non-bougie because we were raised poor. We got trained on how to talk to people heart to heart. Do you know what I mean? If you think about it, in order to convince people, you have to go from your wound to their wound.
Yes.
And in order for people to really trust you, they need to know that you're not patronizing them. And unfortunately, we do that sometimes, even to our own people. So just watching her, just that one young lady, then she started talking to her friends, and then they were all over there. I felt sorry for the poor doula lady, but they were like, they really wanted to know.
Yeah.
I do think we have plenty of opportunity to make a difference when we ourselves even engage and never talk above people, but talk straight.
Ms. Wilson, you are one of the few, if only, philanthropists that's on these panels, part of these discussions today. So I really do want. What's that?
You need a whole lot more.
Yes,
so
we do. So tell us what your role is in Fund to Foundation. What do you do? What does the organization do? And what is the role of philanthropy when it comes to treating and taking care of Black pregnant women?
Well, we're kind of a new foundation. We're a private foundation. We're not the endowed old family foundations, but we were started by Robert Frederick Smith, the guy that is known for the Morehouse gift in 2019. And his whole methodology is about wealth. So we kept pressing him that, you can misspell wealth with WHEALTH because the disparities in the world are very health related as well. And so actually we kind of fell into Black maternal health out of our social justice work. It didn't plan to do it, but when I kept meeting all these wonderful women that were even up here on the panel, I was impressed by all the knowledge and the work that's being done on the ground. So we decided to bring a group together and see, because once again, Panther, we believe in sparking and then get out the way. They have the answers, they have the knowledge, the commitment, but all I can do is bring them together so that collaboration can be more natural. Philanthropists have been saying, collaborate for the last 4 decades, but never making the resources available to do so. You have a lot of convenings, but they just, I don't know, I could say very improper words, but I am representing an organization. But,
it's okay. We can bleep them out if necessary.
Once again, a white male model, we keep following those things when really we need to be more holistic in the way that we put people together. So we did bring, in 2022, a group together, and if you, like I said, get out of the way, we came up with task groups and people started working. And also, what we discovered is that it's very difficult not to pitch your own projects. And I'm a firm believer that projects are wonderful, but in actuality, you almost have to leave that at the door in order to collaborate, in order to find that meaningfulness. So, and we also found out that, quite frankly, people were burnt out. So I would notice on Zoom calls, people would be almost nodding. So what we did was we took them up to Robert Smith's ranch, and we went fly fishing, and they were not allowed to work.
Oh.
And literally, they fly fished, they did archery, and just relaxed and got to know each other, because that trust again, if we don't trust each other, we found out that a lot of people weren't working well together, that, you have different terminology. And so we brought them together, and some people came home and quit their jobs, though. We didn't mean for them to do that.
So they're full-time philanthropists now, basically.
Good gracious. I was like, no, get another one, I hope. But then we took them to Puerto Rico, and we worked with the folks there. In other words, bringing people in together to come up with stuff rather than pitching self all the time. Yep. If we're talking about community, we have to learn another way of being together. Mm-hmm. And it's almost like ancestral memories that we've lost, the indigenous way of being. But at the same time, I'm not going to romanticize everything that's non-Western, but you need the blend. You need to find that sweet spot of the polarity between the Western crisis and the Eastern preventive. And if we can do that, and we can. I mean, you've heard those women. I mean, I'm just awed. I'm like, why am I up here? They've got it. I mean, we've got some solutions I'd like to share at some point. Yes. But because deep down, we live the statistics. I don't even need to know another data point.
What is the greatest need that you're seeing in your organization? Like,
in my organization?
Yeah, when you're dealing with pregnant women, like what is the
I think they already said it. I think earlier it's just the lack of awareness of who we really are and and listening to us. We have said it all. I mean, all I could think of was, okay, so we've got all the data, but now what do we do about it? So and that's what I see, a lack of, if I could even say, time to coalesce. I mean, Dr. Parrott and I have been trying to get together for what, 2 years? It's like, I got to go out of town, got to come. I'm going, so-and-so's graduating, blah, blah. It's like, that to me, I firmly believe we have all we need. We just don't have the space, the sacred spaces to come together to do it in a timely manner without denying other parts of ourselves.
Lauren, how do you create that space? I mean, you're a busy mom, and but there is that need.
I think that that's a great point about being a busy mom. I have to acknowledge that. But I really appreciate, even right here, having this conversation, this intergenerational conversation, right? We can do this at our homes and our tabletops. Having conversations with our aunties, our grandmas, our people in the community who can share their stories and their experiences, because sometimes thinking about birthing stories, some people have had traumatic stories that they've held in for so long, and thinking about how when you hold in that pain for so long, how that impacts you, how you see the world, how you might want to interact with the medical care system in the future, right? So I thinking about space and creating time, just in your day-to-day when you're talking to someone. If you see someone pregnant in the store, give an encouraging word. That was something that was helpful for me. I'll never forget, I saw one more time, I was buying some shoes because my own shoes didn't fit, and I love shoes. And this woman said, you should probably just prepare for a C-section just in case. And I was like, that was odd that she said that. And she wasn't trying to be fearful. She was saying that from a place of love, to say, people prepare for all birth options, but people don't know that there's so many other birth options because you've been so exposed to one thing. But having those conversations just naturally and organically with people who you interact and appreciate. And I do appreciate what you said about creating space that includes rest as well, because when we're all thinking about our own self, our own things we have to do, our own agendas, I think sometimes that fogs us from being able to see the future of opportunities that could come together if we just had the time to sit back, talk, and share.
What was that like to share your story? I mean, that was so personal, and I mean, that takes a lot of courage. What made you decide to even do that?
Well, so I will say I was so appreciative of Fund 2 Foundation and being able to share. I shared stories before I even had the baby, before I had Noel. I was sharing stories about how I wanted to look and then following up after that. So I so appreciate that experience. Thank you. And for me, it was healing, because what you don't see also is that my grandmother was in the house with us that day, and also my mother. And so we have a story about intergenerational. And so my grandmother had a stillbirth. And so she got to talk about that experience. And then my mother got to talk about, she was 19 years old when she had me, and she was in college at Hampton University. And I eventually went to Hampton University, and I'm a proud graduate, and so that's my brother. But think about my mom to stay there and to graduate, and think about those experiences, right? But we don't get a time to talk. So I think it was healing, and I say that for me, I got to share, because I never really got to talk about the C-section afterwards, because I was so traumatized. But then thinking about the healing that my grandmother and my mother got to share from sharing their experiences too, and to be so open and vocal about it, and to find some peace there, and to hopefully bring about solutions and more conversations about how we can have more healthy solutions for Black women who are birthing.
That's great. There was a woman in the documentary who said something like, we have to mourn the pregnancy that we thought we were going to have and celebrate the pregnancy that we did have. Did you go through that? Because you had an unexpected C-section.
I did. I couldn't even look at my C-section scar, and the nurses kept coming in like, "Oh, they did a good scar. Who did your work?" And I said, "Oh, thanks." You know, I got excited about that, but I couldn't even look at the scar for several months because it just wasn't what I wanted. I really thought I was just going to go in there, do my deep breathing, smell some aromatherapy, have the oils. People were going to rub my feet and head, and that's not what I had, right? And then my baby was in NICU because she swallowed meconium, so I didn't have that chest-to-chest time. But I was mindful of afterwards, what can I do to heal so I could be a better mom for her and for myself, because it really could have put me in a dark place. So just being mindful and having the community around me to keep on pouring into me and loving into me afterwards to celebrate that I did have a healthy delivery and my baby is here and thriving.
Thank you. So I'm being told that we only have 5 minutes left, and this conversation has gone by so quickly. So I will ask the final question to all of you. The theme is hope, challenge, and so many of the videos too were very hopeful, right? And we are in such a crisis situation at this time. So I'm curious as to what gives you that hope. I mean, then that emphasis to be positive and to see a better future. Each one of you.
Can we start? Sure.
Yeah, sure.
What gives me hope is young people. And they really want a just world, right? So each generation gets more closer to this idealized what we've been fighting for since we've been stolen from the shores of Africa, right? So I am hopeful when I see Black and brown and indigenous and white students who come up to me, Asian students who are like, I want to learn about reproductive justice. I want to learn about what happened to Black midwifery. I want to understand why you think doulas and midwives should be expanded in this country. So that's what gives me hope, the curiosity of youth, and that the evil forces are dying off, and they are struggling with the fact that they're dying off. So you are the future, and I'm grateful for you.
Thank you.
I think what gives me hope is that thinking about, we're in this space right now, Johns Hopkins, right? And thinking about there's funding and space here to hold these kinds of conversations and what can spark here and bring about change in the future. And how these institutions are starting to see that there are values for listening to Black and brown voices and indigenous voices who might have been historically overlooked. But we're creating space in these spaces to address those wrongs that have been done for us for decades and centuries in many cases here in the United States. So that gives me hope that we are creating change. We are having spaces that weren't really for us from the beginning, but we're now able to have those voices heard and appreciated.
And Ms. Wilson, you can also add your recommendations too, because I know you wanted to, the hope and the recommendations to wrap it up.
Well, a big hope is that Fund2 Foundation also has several projects. For example, Intern XL, which has 21,000 vetted African-American, basically students who are involved in STEM in particular. And what we've discovered is 60% are interested in the health field.
Right.
However, they are having trouble finding internships. So if you have any ways to help us get that done, because what we discovered is it the biology or there's one course that just knocks people out all the time.
Organic chemistry.
I knew I heard
organic
about
chemistry.
I cannot tell you.
It's the great divider. It's the great divider.
So my hope, we provide tutoring for that so that we can have that, as well as we have a learning management system, or we call it a shadow academy, that puts that information out. And we've also had the youngsters help each other with the MCAT. I just got a donation of MCAT books. In other words, once again, my hope, my belief is that if we sit down and talk, we can share. Big example is one of our clinics that we work with said, we're running out of prenatal vitamins. And somebody on the call said, I have several cases of them in my garage, and sent them immediately. And this is what we do. If we would live like that, isn't that indigenous living, really, if you think about it, community living? And that you don't need a grant for that, There's so many things. Please look us up. We're doing all kinds of things with HBCUs and, taking vulnerable women baskets, prenatal baskets. So there's a lot of hope. I just think we need to amplify the messages so that we can get off of the fear-based mentality.
Excellent, thank you. And we have one of those baskets here that we can show our audience. I think it's right in the side, and we'll bring that out so people can see what you're talking about. But it's really kind of an amazing collection of things for the mother and the baby.
Yes, and once again, if you all have messages you want to get out to the, for example, if you think about 21,000 students on a platform that are now ready to vote, right? So we have a campaign starting like, okay, you're 18 now, are you voting? And getting them to know how to vote, and also, not how to vote, we can't do that, but
physically though, right?
Physically getting out there, as well as sending
early,
those
vote often.
letters in that you all are talking about. They need to get in the practice of that early in their lives. So, yes.
Excellent. Well, I think she's going to bring it out. She's going to bring it out, yeah, so we can see it. But yeah, I mean, that really is
We call them Moses baskets. So
and what is in the basket? Can you explain?
Oh my gosh.
There you go.
It's a whole bunch of, well, what we discovered was that a lot of countries, when a woman has when a woman has a baby, they're given products. And I think we had one of our staff who's in Sweden, and they tried to give her that, and she said, "Oh no, I'm not paying for that."
Right.
So, but she didn't realize it was free. So what we put,
and you said there were $1,500
worth of stuff for
stuff.
mommy and baby, so that it's helpful for the first 3 months at least, you know. And things like nipple cream and all for both a C-section as well as a vaginal birth, so that people have things. Believe it or not, it's very expensive at that time. You already, if you've had a baby, you know.
More focus on the, after the birth.
That's right.
It's so
That's
important. Well, thank you, all of you, for giving us that hope and for telling your stories and being courageous in doing so. Thank you. Okay.
Get the basket in the picture.
Hey, yeah. This is now, is this being auctioned, or what's happening with this? Is this being auctioned or given? What are we doing with it today? Yeah, raffled. Okay, so here it is. Okay, so serving two roles here, I'm going to step back into the Mistress of Ceremony role. And so thank you for a wonderful fireside chat. And so at this time, it is my distinct honor and privilege to welcome back to the stage Dr. Roland Thorpe. He will introduce our keynote speaker.
Okay, all right. Thank you, Lauren. Today, we are very fortunate to bestow the first ever Hope Challenge Award in recognition of a leader who's gone above and beyond the call of duty to advance health equity. Today's award winner, who is another exceptional woman named Lauren, Congresswoman Lauren Underwood, who, by co-sponsoring the omnibus legislation and co-founding the Black Maternal Health Caucus, which advances policy solutions to improve maternal health outcomes and to end disparities, has been at the forefront of the fight to save the lives of Black mothers and infants through policy change. Congresswoman Lauren Underwood serves Illinois' 4th Congressional District and was first sworn into Congress on January 3, 2019. A registered nurse, she is the first woman, the first person of color, and the first millennial to represent her community in Congress. Representative Underwood also co-chairs the House Democratic Policy and Communications Committee and serves on the House Committee of Appropriations. She's a graduate of the University of Michigan and Johns Hopkins University and a lifelong Girl Scout. Congresswoman Underwood resides in Naperville, Illinois. Please join me in congratulating the 2024 Hope Challenge Health Equity Award winner, Congresswoman Underwood, for her stellar service and for bringing out our keynote remarks today. Thank you, thank you, thank you. I think they want us over here for the photo. All right, thank you.
We're going to do several things.
Oh.
Okay.
Sure.
Yes, yes.
Oh, okay.
Come on, just everybody, come on.
I'm going to package this back up for you. You're welcome.
Well, good afternoon, everybody. My name is Congresswoman Lauren Underwood, and I have the honor of representing the 14th District of Illinois in the United States House of Representatives. I am a co-founder and co-chair of the Black Maternal Health Caucus, and I am so delighted to be joining you for this event, and I am so grateful for your commitment to saving moms' lives and ending our nation's maternal health crisis. I would like to begin by thanking Johns Hopkins President Ron Daniels and the Johns Hopkins University Nexus Award judges and the Center for Health Disparities Solution Director Daryl Gaskin, alongside all of their incredible partners, students, and staff. Thank you so much for presenting me with the first ever Hope Challenge Award. As a proud nurse and Hopkins alumna, it is especially meaningful to be recognized with this award. Thank you. I stand before you with so much gratitude for this recognition, and I also want to just take a moment to celebrate how far we've come. I am so grateful for my time as a student at Hopkins. My MSN MPH paved the way for my career in healthcare and my career in Congress. I enrolled in Hopkins in 2008. I was a 21-year-old nurse. I had just completed my BSN 8 weeks before moving to Baltimore. I was intimidated during orientation by my classmates who had these incredible credentials. I met two friends on my first day of class, Shalon, who had already earned a dual doctorate in sociology and gerontology, and Reagan, who was a practicing OBGYN. The three of us had joined the MPH program with a mission to end health disparities and improve the way underserved Americans experience healthcare. 9 years later, in 2017, I was wrapping up my service in the Obama administration, and Shalon gave birth to a beautiful baby girl named Soleil. A few days after giving birth, Shalon began displaying serious signs of postpartum complications. She went to the doctor 3 times during what would be the last week of her life. Shalon died of a preventable pregnancy-related complication. Her death was devastating. Her death inspired me to take on maternal health issues when I was sworn into Congress in 2019. I teamed up with Congresswoman Alma Adams in April of that year, which is now 5 years ago, which is so crazy. And we launched the Black Maternal Health Caucus. We were honored to be joined by then Senator Kamala Harris. And what a journey it has been since 2019. I am so proud to have reached this milestone together. See, when we first started the Black Maternal Health Caucus, we thought it would just be us. We wanted to work on this issue, so we started a caucus and we gave ourselves a name because that's how Congress works. But it wasn't just us. In fact, we were blown away by the response. With 53 founding members, we created the Black Maternal Health Caucus to organize around the goals of elevating the Black maternal health crisis and advancing policy solutions to improve maternal health outcomes for all moms. Since then, we've grown to become one of the largest bipartisan caucuses on Capitol Hill. Moms across America are demanding a comprehensive solution to our maternal crisis, and so we looked at the data, we talked to the experts and community leaders, and we wrote the Momnibus. Now, the Momnibus is a comprehensive package of 13 evidence-based bills that address every driver of maternal mortality, morbidity, and disparities in the United States. And when I say comprehensive, I mean comprehensive. The legislation includes investments to grow and diversify the perinatal workforce, to improve data collection, to fund community-based organizations, to expand access to housing and nutrition and healthy environments during and after pregnancy. We're supporting moms with maternal mental health conditions and substance use disorders. Honestly, it is designed to solve our nation's maternal health crisis. And I'm glad to say that my colleagues in Congress are recognizing that. Last year, when we reintroduced the Momnibus for this Congress, we did so with more than 200 original co-sponsors between the House and the Senate. As a caucus, in just 5 years, we've made huge progress. We've enacted sweeping policy changes that are expanding access to high-quality maternal health care and providing robust support throughout the perinatal period. We've passed the first Momnibus bill into law, the Protecting Moms Who Served Act. This bipartisan legislation invests in world-class maternity care for our veterans, and President Biden signed it into law in 2021. And now we've already introduced a successor. It's called the Maternal Health for Veterans Act. Now, earlier this year, the House Veterans Affairs Committee held a hearing on that bill, and I was honored to testify in support. And it's not just in the House. A few weeks ago, the Senate Help Committee held their first hearing this Congress on the maternal health crisis, where Chairman Bernie Sanders called on Congress to pass the Momnibus. Now, back in 2019, we also knew that this crisis needed better research. So we met with Dr. Francis Collins at the National Institutes of Health and explained the problem. And he got it. So after the meeting, NIH pulled together separate funding streams into what's now called the Improve Initiative, implementing a maternal health and pregnancy outcomes vision for everyone. 5 years later, we've increased funding for Improve fivefold. And last month, we introduced bipartisan legislation to make it permanent with Senators LaFonza Butler and Katie Britt. Last year, for the first time ever, we also got funding for HBCUs and minority-serving institutions to study maternal health disparities. And now that funding is rolling out to universities across the country. But that's not all. In the 2024 federal funding package the president signed last month, we secured more than $100 million. Let me say that again, $100 million in funding for Momnibus priorities. And that's on top of the $100 million that we got last year in fiscal year 2023. So exciting. But we still have a lot of work to do because we know that our maternal health crisis is only getting worse. It's not getting better. And so the one thing that I really want you to know about this money, y'all have to apply for it. You have to go and get it, right? We secured the money. The money is there. But as stakeholders, which includes all of you, you are the stakeholders. You are the researchers. You lead the community-based organizations. You are the policymakers in state and local government, right? Y'all need to go and get that money. The dollars are for us, and we need to put them to use because if you don't go and get it, we won't be able to get the money again. Do you see where I'm going? Yes. Okay, so after 5 years of working on this issue in Congress, I have never been more hopeful because we have a solution, right? We're not out here trying to figure out how to solve the problem. We know how to solve the problem. The solution is in hand, and that solution is called the Momnibus. And we have to work with a great sense of urgency to get the Momnibus across the finish line now. We have a unique political and legislative opportunity this year, okay? And our moms can't wait. The United States has the highest maternal mortality rate of any high-income country. As I said before, this crisis is only getting worse. The maternal death rate is 89% higher than before the pandemic, and disparities have worsened. If there's anything that I want you to remember from today, it's that 80% of the deaths that we see nationwide are preventable. The Momnibus is not a Band-Aid. It's not a messaging bill. It's not a commemorative resolution, and it's not a study bill. It is the comprehensive solution that can bring that 80% number down to 0. It invests in us. It invests in our families. It invests in our future. Now more than ever, Congress is realizing that this crisis impacts everyone. Americans in the suburbs, in rural communities, and in urban areas. We all have a story to tell about how our nation's maternal health crisis has touched them. The Momnibus solves this crisis for everyone, and Congress must pass it this year. So I am so grateful to all of you who have been partners in this work, and I'm so grateful to the event sponsors who are shining a bright light on this issue throughout the United States. Please be in touch with my office if you're working on these issues or you want to learn more. You can find our Black Maternal Health Caucus website online. Thank you so much for this award. Thank you for the opportunity to join you here today, and thank you for hosting this event. It's so good to see you. Take good care of yourselves. Thank you. Thank you.
I just want to say thank you again to Congresswoman Lauren Underwood. We give her a round of applause as she has to leave. We're just so grateful for her gracing us with her presence, energy, and passion. And listening to her remarks today were really helpful for us to honor the service that she has and the privilege that she has to represent us and the so many voices that are needed in terms of advocacy. So this is the conclusion of the event. So I just want to take this time to thank the entire Hope Challenge team and those who made today's events possible. Many of thanks to those who are in person, who are in the audience, and then also to those who are online. Thank you so much. And also, again, thank you to the panelists for making this a wonderful time here today. For your information, this is the third in a series of Hope Challenge events focusing on leveraging public policy to end preventable health disparities. Our fourth and final event for this series will be focusing on health disparities and gun violence, and it will be held in the same location on Friday, June 4th from 9:30 to 1:30. We invite you to use the QR code that will be displayed in a second to take a survey asking about today's event so you can provide us with some more information. We love to collect data so we can use those things to create more programs and also other services. Okay. We're going to get... It's a Tuesday. That was my typo. Sorry. Thank you for that. Right. Well, Tuesdays are good, too, to have an event. So it'll be Tuesday, June 4th. So please remember that. I'll say it a third time because 3 times is really good for your memory, they say. So Tuesday, June 4th from 9:30 to 1:30, and it will be in the same exact location. So please, when the QR code becomes available, take the time to fill the survey out, provide us with your thoughts on today's events, tell us what you want to know for future events. That'll be helpful for us. Thank you again. And so to reiterate, we were going to have lunch upstairs. So we're in the bottom level, but we're all going to come together upstairs, have more conversation, more dialogue, and hopefully come up with some more solutions so we can address the disparities that we talked about today. Thank you again for attending, and have a good holiday weekend. Thank you. Eighth floor.
I'm Crystal Purtle Tyler. I use she, her pronouns. My formal training is as a reproductive and perinatal epidemiologist. And in short, it means that in my formal training, I studied Black babies and Black mothers and how to keep us healthy. And I specifically focused on the impacts of racism and policies and systems and how it has caused negative health outcomes for Black babies and moms. I was like in kindergarten or first grade, and people would say, what do you want to do when you grow up? And I'd say, I want to save Black babies. I think my parents were the ones who kind of said, whatever it is, go as far as you possibly can. And I'd say at the point I'm at right now, it's my peers who are really my village. Those are the people, the women who I call on when I'm having a bad day. We lift each other up and really kind of wrap our arms around each other. And in terms of accountability, because I think that's a big part of a village, I would say that's my 10-year-old daughter. She's the one who always keeps it real with me. My Black birth story, it actually started maybe during my dissertation process when I really started to understand the potential outcomes if I were to give birth and have children. And so I was working at the Centers for Disease Control at the time in the Division of Reproductive Health when I got pregnant. And I will say that I made the decisions that I made, the birthing decisions that I made, mostly out of fear. I was scared that if I went to a traditional OBGYN, if I got an epidural, that would slide me down this path of then I'm gonna have a C-section, then I'm gonna have a complication, then I'm gonna die. I'm a Black woman, good in that really good age range for being pregnant, highly educated. Not only do I understand pregnancy, I have a PhD in this, and I'm trying to guard against death during this perfectly natural experience of having a baby. That's outrageous. But that was what I did. And so I chose a midwife in Atlanta who would support those decisions of a completely unmedicated birth. I birthed in a hospital in Atlanta, and it was a water birth. And it was intense, it was long. My son came out, he was facing the wrong way. Basically, when babies come out, they're supposed to come out with their head down, facing back. And the issue with babies being OP is that they don't properly push against the cervix, and so you don't properly dilate. I'd been laboring for 20 hours, 21 hours, unmedicated in the water. I wasn't properly dilating. So at about 6 centimeters, the midwife said, you know what, forget this, I'll just do it manually. So she manually dilated me from 6 to 10. And it wasn't any more painful than the labor. Very hard to find someone who would respect my birth wishes. And so I did a lot of Googling, and I found a midwife, I'm not gonna say her name, a Black woman, begged her, please, please, please take me as a patient. Please, please deliver me. I'll be so easy, I've done this before. You basically don't have to do anything, it'll be fine. And she agreed. That second experience was so wonderful. I expected to labor for 20 hours because I did the first time. And I remember being in the house laboring, and I was in the shower, and my husband came in and he goes, I think maybe we should go to the hospital. This was maybe like 7, 8 hours in. And I said, no, it's gonna be a long time. We got time. He was like, I think we should go. So we got to the hospital and they said, okay, how long have you been laboring? I don't know, 7, 8 hours. And they checked me and they said, you are 8 centimeters dilated. We need to go. She's gonna deliver now. So the midwife showed up and 30 minutes later, I'm in the tub at the hospital laboring. And she says, you can't push in the water. You're gonna have to get out of the water. And my whale-sized 9.5-month, I'm not getting in the tub. She lets the tub. She's like, there's no water in the tub. And I said, out. So my husband hit up out of the tub. And in a couple, that one was a better. Watching everybody in the field, I proudly shout needs to happen. I think because we're not there, because this work is loudly, and people who you never speaking about health, I think that visibility narrative around is really what gives me hope about the future coming behind. And I know that they are not, and they're going to push until are the way they need to be. That we're striving for are achieved. And it's know that you get tired and you get exhausted, you get cranky, and also have times of joy and then you have wins in political, you have loss in life coming in. Just realize that this is all the journey for new narratives of hope. It's to be seen. It's our stories to be. Join us. Shine a Black birth story